Welcome to the 2025 Rocky Mountain IBD course, 2026 actually, sorry, 2026, lost track. Thank you for coming. We've been doing this many years. I see some familiar faces, really appreciate everybody coming, and to those of you that are here again, welcome back. I think we've got a great course for you today. John Valentine from Utah and I have been working to put together good content for you, and I think it's going to be very educational. CME and MOC credits are available for eligible sessions. Talk to Christy right there at the front desk to get set up for CME. There's also something that you can scan to get CME and MOC credit. Huge thank you to our top-level exhibitors, our diamond sponsor, Johnson & Johnson, our platinum sponsor, AbbVie, and our gold sponsor, Takeda, Entyvio, and Eli Lilly. And then also thank you very much to our silver and bronze sponsors as well. We really couldn't do this without your support, so thank you very much. And we've got Bingo, so get your Bingo card stamped. I think there's a $100 Amazon gift card for the winner of Bingo. John, anything?
Yes, we couldn't put on this conference without the sponsors, so we do appreciate that. Was this our 11th year?
Yeah.
Yeah, so our 11th year. We are planning to do this again next year. We will be asking for your feedback at the end because we always want to make this conference better.
Yep. Thanks, John. And with that, why don't we go ahead and get started? Our first speaker is going to be Jessica Johnson from the University of Utah. Should I stay or should I go now? When to salvage and when to move on from a therapy?
Thanks, everybody. I'm really excited to kick off this early morning with this topic. Okay, these are our learning objectives that we're going to cover this morning. And hopefully at the end of this 30 minutes, we'll have a framework to answer or address this really complex clinical question that's summed up so well by The Clash, 1982, British punk. Should I stay or should I go now? If I stay, it will be trouble. If I go, it will be double, right? We're always worried about making things worse. No disclosures. So when we talk about changing IBD therapy, we're going to look at the whole picture. When we're asking the question, is this as good as it gets? We're taking into consideration disease characteristics, severity of disease, duration, patient characteristics, how therapy exposed are they? Do they have comorbidities? Access to various therapies, efficacy of the therapy we're thinking about switching to, and safety, of course. Treat to target gives us this excellent framework for taking care of our patients. It gives us the target of therapeutic goals of sustained remission and mucosal healing, preventing complications of disease and side effects of therapy, and accounting for patient preference and quality of life. Sounds really nice and neat. We're going to talk about this part of the cycle today. So you've picked your therapy. You've picked your therapy, you've started it, you're going with it, but for how long? And then what happens when you get to this reassessment point and you haven't reached your target? What do you do next? So that's when we start thinking about changing therapy. So some of the indications to change therapy, if you have an ineffective therapy, either a primary non-responder or someone who was well for a period and then had a secondary loss of response. Maybe the patient's got accruing comorbidities with age or they're not tolerating said therapy. Maybe they've changed their insurance coverage. There's a variety of reasons that these questions come up. Objectively, according to Treat to Target, right, you're following objective measures, ongoing biochemical, radiographic, endoscopic inflammation, or inadequate drug levels if you're doing TDM, or steroid dependence, that patient that's calling in for tapers over and over again. And when we're talking about changing therapy, there's really some terminology we should go over, right? We're balancing potential risks and potential benefits. So you may think about switching your therapy, which would be changing the agent. That can be within class or an out-of-class switch, like going from a TNF to a JAK, for example. And then you're also thinking about, on the other side, optimizing therapy. So this is a strategic approach to try to make your current agent work better. And that may include dose intensification or escalation. Those terms are sort of used interchangeably. Or, and that's, higher dosing, more frequent dosing, salvage therapy, rescue doses, et cetera. You may have a role for therapeutic drug monitoring depending on your agent, which we'll talk about in a minute. And you may think about combination therapy. So you're really asking in this setting of optimization 3 basic questions. Is there evidence of any improvement on this therapy? Do we have a glimmer of hope? How sick is your patient? How much time do you have? Are they still steroid responsive, or are they getting progressively sicker? And then, is there an option to optimize this current therapy? Can you reload or increase the dose, or are you already at the top of your therapy? And how often do we need to escalate therapy? We know from registry data of 20,000 patients on biologics that it's super common. Over a quarter of patients on biologics need dose escalation. And it's, more common depending on certain agents. The good news is that clinical remission is recaptured quite frequently with dose escalation, and it's durable. So going back to our 2 strategies for changing therapy, you're gonna lean towards optimization when you've got a partial response. You think they're gonna get better with optimizing this agent. A flare after a period of remission. Maybe your patient has very few remaining therapies. In that setting, you're gonna wanna hold on to this one as long as you can. Or if you're doing TDM and there's room to optimize your drug levels. You're gonna think about switching therapy if you have inadequate improvement despite an adequate trial of therapy, ongoing inflammation after a cycle of optimization, maybe your patient's too sick to keep going on that agent, they're having side effects to therapy, or if you're doing TDM and it shows that there's really no room to make this particular drug work better. To highlight this, TDM is obviously much more robust with our anti-TNF agents, so we're gonna talk about that for just a minute. So everything above this red line speaks to optimization. If you have low levels and no or low antibodies, you have room to make this drug better, so optimize. Everything below this line is on the side of switching. If you have low drug levels and high antibodies, you're clearing the drug, you need to move on. And if you have really good drug levels and the patient's still sick, it's not the right drug, you need to move on. These are, busy slide, these are different trough levels for anti-TNFs based on induction phase or maintenance phase. And then down here at the bottom is to highlight that higher drug levels may be indicated for different indications, like fistula healing requires a higher infliximab trough, we think. I added this just for completeness. This is still controversial in some areas, whether or not TDM for anti-integrin and anti-IL-1223 is predictive of these response. It's certainly associated with response. So these are the numbers that you would kind of shoot for if you are going to do TDM for these versus empiric optimization. Okay, so if you've got your therapy on board, the patient has not responded the way that you would like, and you do TDM for your anti-TNF, and you're therapeutic, and you have a mechanistic failure, you're going to switch. If you have low levels and no antibodies, you're going to optimize, or low antibodies. And if you have high antibodies, you're going to switch. This is like the most straightforward, right? This is the one where we all feel good about this. On the other side here, we've got the non-anti-TNF agents, which thankfully there are more and more. There's no universal TDM recommendation, and it's difficult to know what to do here. And so we're left with this statement of consider individualized dose escalation or out-of-class switching. So this is where we start to worry that we're making people worse by trying to make them better. I put this slide together based off of clinical trials data, prescribing information, real-world data. This is a rough estimate of when to expect your patient to be better and when to start to think about stopping your drug. The dark part is this predicted time, weeks to response. You got your fast actors, infliximab, JAKs, your intermediate actors with your IL-23s. And then the light line is when you're starting to think, okay, I think this is as good as it gets, all the way out to 6 months here for your 23s. These numbers are more reliable in certain scenarios. Earlier clinical benefit and kind of following the rule book is more expected in less severe disease, more recent disease, and then importantly in your therapy-naive patients. So why is prior biologic failure such a big deal? Patients who have failed a prior biologic are often likely to have decreased efficacy of their next agent. It's associated with lower and slower rates of remission, lower treatment persistence, higher rates of switching, less effective optimization strategies, and the more you fail, the worse it gets. This may be because the disease kind of escapes the mechanism of the drug. It may be cleared based on antibody clearance. The disease just may get more severe over time. We don't really know. But we kind of break it down into these different types of failure. We've got secondary loss of response with antibody formation, where the patient's immune system is clearing the drug after a period of remission. That's probably the least significant in terms of affecting the next therapy. Then you've got secondary loss of response without antibodies, where they were well, they got worse, and you check their levels and everything seems to be fine, but they are not. That's intermediate. And then primary non-response, which can happen in about a third of patients. That's the most significant for poorer outcomes with your next therapy. So what are we gonna do? You wanna pick your next agent thoughtfully. Think about all these wonderful new tools and toys that we have. Your JAK inhibitors appear to have similar efficacy in biologic exposed patients. Anti-IL-23s are probably intermediate. You don't want to pick a lateral move or a step down, basically. And then think about optimizing your next agent early. Maybe go ahead and plan for an extended induction or a high-dose induction. So we're going to go through these agents pretty quickly. Our old friends, the anti-TNFs, you expect a rapid response to therapy within a couple weeks. We've been through this flow sheet here. If your patient's not doing well and you do TDM, this is helpful in optimizing therapy. You're going to get your highest drug levels with your shortest intervals. So when you think about your optimization strategies for infliximab, you can dose increase, you can shorten the interval. Adalimumab, shorten the interval or reload. You would expect to see some benefit within 6 weeks of doing this. And then old school combination therapy, adding your thiopurine, your methotrexate, trying to either boost the drug level or the potency of the anti-TNF, or potentially have an independent effect on the disease course. Because there's these different mechanistic ways that combination therapy helps, the expected benefit is variable, but it's usually weeks to a few months. For your JAKs, fast onset. If you're not seeing any glimmer of hope by week 16, turn the page. These are some of the recommended doses. Maintenance doses are considered a little bit lower potentially, and then these intensification options, which you would think about in your patient with a partial response, or your very sick patient or your very therapy exposed patient. For UPA, more than 50% of people with a partial response at 8 weeks will continue to benefit with another 8-week period of induction therapy at the 45 milligram dose. Both agents, if you drop the dose during maintenance phase and your patient starts to flare, you can recapture response by bumping their dose back up. You can consider high-dose maintenance. There is emerging data to suggest the safety for UPA 45. TOFA, I think most of us have our patients on the higher dose for maintenance just because they've been therapy exposed prior. And then interestingly, you can switch within class with these two. More data suggests benefit going from TOFA to UPA, but I have seen the other way as well. So they are slightly different medications. If you have a partial response on one, it's not crazy to think about going to the other. And then again, rapid benefit. For ustekinumab, Stelara, and biosimilars, symptom improvement at 3 to 6 weeks, full benefit up to 6 months. Early response predicts good long response. So this is one of those early, you want to look for this early response for ustekinumab. Unclear role of therapeutic drug monitoring still being worked out, whether there are proactive goals or not, whether you need to do reactive monitoring or just empirically dose escalate, still unclear. But you do want to think about optimizing, particularly in the patients that lose efficacy over time. This is common with ustekinumab. And so more than half of patients will ultimately need dose escalation. I feel like it's even more than that potentially. But remission after dose escalation is common. So you can shorten your sub-Q intervals from every 8 to every 6 to every 4. And there's data to say just additional IV booster doses may also help kind of maintain that efficacy and expect benefit within a couple months. Anti-IL-23s are new kids on the block. You're gonna see symptom improvement pretty quickly, but full benefit can still take up to 6 months. I put this question mark next to escalation of therapy because I don't want people to think this is a known thing yet, because it's not. I mean, we're extrapolating from all of our other agents that say more is better and sicker patients need more drug, and kind of applying the same thought process to these newer drugs with a tiny bit of data. So for risankizumab, you can consider IV reinduction or shortening your intervals based off of some clinical trials data, and then these really tiny case series here that showed improvement with dose escalation. Mirikizumab, potentially extended induction or reinduction, and guselkumab, if your patient goes on to low-dose maintenance and flares, switching them to high-dose maintenance, and then see benefit within a month or 2. Finally, for vedolizumab, our slowest agent, symptom improvement 6 to 10 weeks, full response around week 14, but in your exposed patients or your Crohn's patients, you may think about 18 to 22 if they're not too sick. We, again, are not sure about the role of TDM in terms of just empirically optimizing if they start to flare or are a partial responder. But you want to think about optimizing if your response is inadequate by weeks 10 to 14. You can do an early induction dose. You can shorten the maintenance interval, that's every 4, every 6 weeks on IV or weekly on sub-Q. And then some evidence suggests that switching from IV, even every 4 weeks, over to sub-Q is actually not a lateral move or a step down, it's actually potentially a step up. So sub-Q maintenance may be a tool to optimize someone who's flaring on IV. Benefit 4 to 8 weeks. Okay, so to wrap this up before we get to my case, should I stay or should I go now? Step 1, confirm the need to adjust your therapy. Make sure you have objective evidence of inflammation so you're not tinkering with something that's not broken. Step 2, assess the situation and decide whether optimization strategy is advisable or if it's better to just switch. You want to know if there's been evidence of any improvement on this drug. Has the therapeutic trial been adequate? How sick is the patient, and what are their other options? Then make your plan, whether you're going to optimize or switch. If you're seeing partial clinical response, flare after remission, if there are lots of options to escalate and intensify this particular therapy, if your patient doesn't have a whole lot left, and then based on TDM showing low levels, you may think about optimizing. On the other side, if you've got inadequate improvement despite an adequate trial of therapy, if you've already done a cycle of optimization and they're not better, if your patient's too sick or having side effects, or if TDM suggests that you need to move on, you're going to think about switching. So always asking, is this as good as it gets? And looking at our cycle from treat to target. Make your optimization plan be realistic. Is there room to optimize? Is there time to optimize? Will insurance cover it? Switch agents thoughtfully based on mechanism, patient factors, and safety. Think about optimizing your next agent early, be ready. Follow your objective markers and adjust your time points based on how therapy exposed your patient is and how many options they have left. And then have your plan to use treat to target to recycle your workup and a plan for your next therapy. Okay, I could have skipped all of those slides and just put this big mamma jamma up here. This is a summary of the information that I gathered to put this talk together. Okay, so for my case, I have a 40-year-old patient who has only a prior history of melanoma in situ, otherwise she's healthy. She develops symptoms, she has her colonoscopy, and she has extensive ulcerative colitis. She initially goes through a mesalamine trial for about a year. She's better, her labs are better, but then she starts to break through. And we do a prednisone taper, and she's gradually better, but during the taper, her symptoms come back. So should we stay or should we go? In this case, flaring during your pred taper is a bad sign, and she's already on maximum mesalamine therapy, so we moved on. We picked Veto because of her melanoma history. She got a little bit better, biochemically kind of better, but then she got worse, and this was during induction. So we re-scoped her, and now she's got Mayo 3 disease. So should we stay or should we go? In my opinion, in her, in talking with her, she worsened during inductions. Like, she worsened with the start of the therapy. So to me, there's not really room to optimize. There's not a glimmer of hope here. So we moved on to ustekinumab, better. So we checked her trough because she wasn't in remission, maybe low, depending on what you read. So we escalated her to every 6 weeks. So after 6 months total, 3 months of escalated therapy, so she's biologic exposed at this point. We're letting her go, to the outside of the window. She's still got biochemical inflammation, still not feeling well. Do her scope. She's got some proximal healing, but that persistent Mayo 3 in her rectum. So should we stay or should we go? So at this point, she's been not feeling well for quite some time. We're going on a year plus of rectal inflammation. Nobody's favorite. And she's already gone through a cycle of optimization. It didn't work. So at this point, she's ready to talk about anti-TNF despite, the rumblings of risk with melanoma, and infliximab is our next choice with derm follow-up. We went ahead and planned for escalated dosing. She's therapy exposed ×2 at this point, so we started her on infliximab, 10 milligrams per kilogram, a little better. Trough is 23. Scoper, approximately she's okay-ish. Distally, she's still Mayo 3. So should we stay or should we go? I mean, if you believe your TDM for anti-TNF, which is pretty robust, this is a good trough for infliximab for what she's got, and she's still got severe rectal inflammation. We could have added an immunomodulator here, but she was worried about the side effect profile, and so we decided to move on. Fortunately for us, tofacitinib had been approved, so we went to tofa. She didn't do so well. Started back on prednisone. We scoped her quick because she wasn't feeling well, and back on pred. And she's worse kind of throughout her colon. The proximal healing is gone. So should we stay or should we go? So another case where there's no room to optimize the tofa. She's on max dose. She's already on pred. So we moved on and went to UPA. Thankfully for us, that had been approved. So she did her 8-week induction, a little bit better, came off the prednisone, scoped her, and it's hard to tell from these pictures, but she actually did have some patches of normal mucosa here, so glimmer of hope. So we decided to optimize and get a colorectal consult, which she said no. So no colectomy, so we decided to go through another cycle of optimization, and we did UPA for another 8 weeks at 45 milligrams, and she had a partial clinical response, biochemically better. Systemically, she was okay, and here you can definitely see she's got some actual healing. There's still a patch of Mayo 3 in the rectum, but she's, at this point, out of therapies. Realistically, everything's a lateral move or a step down after high-dose infliximab and long-term 45 of UPA in theory, and she adamantly declines colectomy. So we stayed for a year, and then risankizumab came out for UC. So we talked, and she's like, I would love to get off prednisone. I'm not on much, but I'd love to get off. So that was her goal, and we just started risankizumab. She got better. Biochemically, she improved. She was able to come off prednisone again. We gave her a good 8 months because she was okay, and this is really her last therapy at this point. And then we rescoped her, and she looks quite good at this point. It's not perfect. I called her Mayo 2 because she's still pretty granular in there. She's got a bunch of pseudopolyps, but we decided to stay, and that's where she is now. So, thanks.
Thanks, Jessica. Great talk. Actually, really great segue into our next speaker, which is Cale Steiner from the University of Colorado, talking about combining advanced therapies. Which combination makes the most sense? One might wonder whether this patient next move would be to add in something in combination, but Cale will tell us the pros and cons.
Thank you, Mark. Yeah, perfect segue. I didn't even expect that, but this is someone who might get there. So yeah, I'm Cale. I'm one of the IBD faculty at University of Colorado. It's great to be back. Thanks for coming to the talk. I see a lot of familiar faces. It's great. A lot of people come to this conference year after year. If you saw my talk last year, you might be just as surprised as I am that I'm back up here. I thought I might have earned myself a weekend off, but Mark asked me to speak again anyway, and John. So yes, that is how this works. Okay, so we're talking about combining advanced therapies, and I really love that Dr. Johnson called the like the immunomodulator plus anti-TNF old school combination therapy, because that's different, so I got to be careful. But I'm talking about advanced therapies here. So I'm really talking about essentially our biologics and our small molecules and combining those two together. I'm not talking too much today or much at all about the old school, which I'm going to use that now. And you know, I want to talk about which combinations make the most sense, but the truth is I can't tell you what combinations are the best. It's just not, we don't know enough yet. But what I do hope to talk about is what you should consider and what the information that we do have is, because at this point we're really, when we have these patients like Dr. Johnson just presented that are really kind of at the end of the rope, and maybe they need a colectomy, they're refusing it, or we just have to make educated guesses. And so I want to provide kind of the information that you need to help make those educated guesses on using combination therapy. I am going to start with talking a little bit about essentially background, but like talking about combination therapy is not new really. There is old school combination therapy. And then I'm going to spend a lot of time talking about mechanisms, and I'll try not to make it too boring. But I think that's, to me, one of the most important things when you're talking about combination therapy is understanding the actual mechanisms of what they're doing, both regards to which pathways they're hitting immunologically, and then also what these pathways are supposed to be doing in your body, and so what you're potentially tamping down and exposing them to risk for. Then we'll talk a little bit about kind of factors to think about when you're deciding what combination therapy and in whom. And last, I'll follow up with kind of what's been studied already, and that'll be the shortest section because not a whole lot has been studied yet. But talk about old school combination therapy. This was the oldest combination therapy study I could find from 1997, and they combined oral, get ready for it, and topical 5-ASA for distal UC. So you can imagine sitting around thinking, I got this drug, and if I put it in that hole, it works okay, and if I put it in that hole, it works okay. I'm going to put this in both. And in 1997, that was a Red Journal publication. But it worked better. So hitting them from both sides worked. Little more, actually using two different drugs here, antibiotics and adalimumab works pretty well for perianal Crohn's disease. I think we all know this. This makes sense. Antibiotics have some inherent anti-inflammatory activity. We know the microbiome is an important factor in IBD. So, we frequently use antibiotics, especially for our perianal disease Crohn's patients. This combination's a good one. And then, of course, no talk that uses the word combination would be complete without a slide on Sonic. And so this was one of the first trial to look at combining immunomodulator with anti-TNFs and kind of changed our paradigm to like more of a top-down approach than a step up. And I'll briefly kind of come back to that idea because I don't know if combination therapy is ever going to get there, but there are some people looking at combination therapy with advanced therapies kind of first, and so I think that needs to be kind of thought about. And then UC success, the follow-up for UC, kind of similar to Sonic, but for UC. And then we have natalizumab has actually been studied with infliximab started quite a while ago, 2007. We don't really talk about natalizumab. Nobody uses it for IBD anymore. Entyvio is essentially, a very similar mechanism without some of the side effect baggage. But combination advanced therapy has been looked at for, 20 years. So, and it did work better as far as efficacy goes, but there are some safety signals with natalizumab. So why are we talking about combination therapy? I think the fancy term is we have reached an efficacy plateau. So we're at a point where still about 50% of our patients don't achieve, or only 50% of our patients achieve clinical remission despite the good therapies we have. And then even of those patients who initially achieve remission, only about 40% of them will continue to have that response at a year. And it gets even lower when you start moving to second therapies and third therapies. So we've really reached an efficacy plateau. We need to figure out how to overcome that. Combination therapy is one potential avenue to do that. And so taken a quick look at other disease states, have other disease states, have people used combination therapy in other diseases? And the answer is yes. It's been used very successfully in things like cancer therapy, HIV therapy, hepatitis C, in cardiology. They do a lot of combination therapy to address cardiovascular issues, and then even other immune-mediated disorders like rheumatoid arthritis. So that's the background. It's been around for a while, but when we're applying this to our IBD patients, we have to think about what are we doing in the body. And so I'm going to spend some time talking about the mechanisms. And I know everyone here, I'm sure everyone knows, they could tell me what the mechanisms are generally, but I want to kind of get down to like, what is it doing in the body? And so I had these two simple schematics that I brought up to show everybody. I like to draw these out for each of my patients when I'm talking about switching therapies. My reviews are great, but I don't have time to talk about all these, and I'm just kidding, I don't know what's on those slides. I wanted to make this a little more simple, and I tried to find like simplified diagrams to show just what I wanted to show, and I couldn't find any, so I was like, I'm a pretty good artist. So I drew them for everybody. And this only took about 5 hours, so it was worth the time. And so these are the 5 main mechanisms we're talking about today. So we have the TNF pathway, and this is released primarily by macrophages, Th1 cells. And the TNF gets released, and it does stuff. And then we've got antigen-presenting cells. They release IL-23. This acts primarily on Th17 cells, and it does stuff. JAKs are everywhere in the body. They're a cell surface receptor. When they get hit by cytokines, they go do stuff. And then the two on the right are kind of like a separate thing, and we need to, I think about them a little bit differently, but the S1P modulators, those essentially don't allow the lymphocytes out of the lymph nodes or the lymphoid system. And then, of course, our alpha-4 beta-7 doesn't let those lymphocytes into the intestine. So we have antibodies that block these three, S1P, IL-23, TNF-alpha. I think there's some more stuff coming up about other small molecules, but right now those are all, oh, I mixed it up. Oh, I'm sorry. Well, sorry. This one down here, the little small molecule, that's what that is. That should be on the S1P, and then the antibodies down. So I apologize. But then the JAKs and the S1Ps are small molecule inhibitors, so they're not actually antibodies. And that does come into play when we're thinking about which combinations to use. I'll hit on that later. Okay, so TNF-alpha, I already kind of mentioned, this is released primarily by these Th1 cells and macrophages. And what it does is, I don't have a really succinct way to say what it does, because it turns on a lot of things, a lot of different cytokine pathways. The primary cells that respond to it are macrophages, fibroblasts, and neutrophils. And so these are kind of part of the innate immune system, right? So it's not really doing much to B cells. But the innate immune cells are responding to this, and it just generally decreases inflammatory activity. It's important to know that this pathway is important for a lot of bacteria, so a lot of intracellular bacteria, intracellular parasites, and also some viruses here. The IL-23 pathway is a little different. This is released by these antigen-presenting cells, which kind of hang out in the intestine or whatever tissue they're in, and they see bugs, they process them, and they show the immune system, and then this causes the Th17 cells it basically modulates them. It's interesting because the IL-23 system in general suppresses our regulatory cells. So we want those regulatory cells to be doing a better job in IBD because the inflammation's out of control, and so this essentially blocks the blocker. And it has a lot of other downstream effects, and this does have some overlap with the TNF pathway. So remember that those two have some overlap. And this one's really important, again, for bacterial, but also for fungal infections. So that's one thing I think about when I'm putting these on. And some people refer to the IL-23 pathway as like a master switch. So JAKs, these are ubiquitous. They're everywhere. The most important thing to know about these in relation to the other drugs is that there is a lot of overlap with the IL-23s on this one. So essentially, the IL-23 pathway and the JAK pathway, they overlap. They're almost in line. And so if you're going to use these together, which I'll talk about later, you need to know that you're giving kind of a double hit to that system. We know that herpes is a big issue with this, but again, you would think the same system as IL-23, you're going to be kind of doubly making people susceptible to like bacterial and fungal infections, and then some of the other mucous membrane infections, URIs, UTIs, nasopharyngitis. So the alpha-4 beta-7, this, like I mentioned, this blocks the lymphocytes from leaving the endothelial cells. So the lymphocytes, they hang out in the lymph nodes and they float around and they go to where they need to go, but they have to have the key to get in. And alpha-4 beta-7 is the key to get into the intestine. So when you block this, they're really only not able to go into the intestine. So it's not even, it's very gut selective, which is one of the key benefits. And it doesn't have any direct overlap. It would have some indirect overlap just because, you know, you're preventing those immune cells from getting into the tissue, so it'll have some kind of blanket indirect effects. And then, also just gut-specific stuff for this. So there's not really a specific pathway, it's just you're blanketing the immune system. And this is essentially the same for the S1Ps, except for they can't leave the lymph nodes, so you could potentially have some more systemic effects because you're not just restricting egress into, or you're not just restricting migration in the intestine, you're restricting egress out of the lymph nodes. Again, just broad, non-specific infectious risk for this mechanism. So when I'm thinking about which drugs to use for these patients, I start here, and I think about what do I want to use, like which mechanism do I want to use? And I've seen a lot of the literature that's out there, they talk about, and they're not just talking about advanced therapies, most of these review papers are talking about kind of all the different combinations. But there's this thing that, you know, you want to use different mechanisms of action. And that makes sense for some patients, I think. It inherently makes sense because you want to spread out what you're touching. And theoretically, you would have a reduced safety profile if you're kind of spreading out the problems, I guess, if you will. But I can also think of some examples where you actually want overlap on the same patient. And so a lot of this overlaps with the talk we just had from Dr. Johnson. If you have a patient that has, for example, they've tried everything and they had or maybe they've tried everything except for a JAK inhibitor and they had a partial response to IL-23 and you decided to go to combination therapy, maybe you want to give them the JAK with that IL-23 because you think that's the only pathway that might work. You know, our patients are very heterogeneous in how they present. We don't know what the underlying pathophysiology of their disease is, and I suspect that each patient has a very individualized set of components that are contributing to their disease. And so if you have someone that just has a genetic predisposition to have an IL-23 pathway defect, that might be the only place you're going to get any bang for your buck. If you have someone that's only been on maybe one agent or two agents and they didn't really have a response to either one, you might want to think about splitting it up and doing like an anti-trafficking agent with one of the anti-TNF or the IL-23 or the JAKs. So I'll talk a little more about that later, but I'm going to present this kind of Venn diagram because this is how this is talked about in the literature, but I don't think it's as simple as choose ones that are different whenever you can. I think sometimes you just have to be very thoughtful about how you do it. So the anti-TNFs, that's my anti-TNF circle. The IL-23s, they have some overlap. The JAK-Is and the IL-23s have, I would say, the most overlap of all of these, and they both kind of touch the anti-TNF. Our traffickers, I kind of put up the top. They just kind of touch all of it a little bit, and then our S1P, that's one of our traffickers, and our alpha-4 beta-7, they kind of have a lot of overlap, but again, one of them is just very gut specific. So, you know, I started drawing this. I didn't really have a plan for what it was going to look like when I was done. I don't love it, but I think it gets the point across. And I kind of hit on this already, sorry. But so we got, I kind of think about these as like high, I had to put this a caveat here because these are all some overlap, right? So in the literature, they talk about like, they basically lump all three anti-TNF, IL-23s, and JAK-Is as like high overlap, all of the anti-traffickers with the other ones as kind of medium to high. And then, you know, you can talk about like using an immunomodulator, which would be like, you know, complementary, no overlap. All of these have some degree of overlap, but within the context of choosing advanced therapies, this is how I think about them. So your really low overlap is going to be your traffickers and then your pathway modulators. And then you got some mediums with the JAKs and the anti-TNFs and IL-23s, and then the high with the IL-23 and the JAK-I. All right, we got through that part. That was going to be, I think, the most dense part. So deciding on which combination to use and who, we're wading into the area of opinion here, so I'll give that caveat. There's not a whole lot of data on this. So even just choosing which patient to use, we don't really know. We don't have good biomarkers for what patients are going to respond better or not as well to combination therapy. I can't tell you if you should let them fail 2 or 3 or 1. It's very patient specific. It has to be a discussion with the patient. And so all I can really say about choosing these therapies is typically, most commonly currently, we use this in refractory disease. These are people that have probably failed 2, maybe 3 or more therapies. You can also think about this in people that have really high-risk disease. You're really worried about complications. One area that does seem to work really well is concomitant immune-mediated disorders, but this is a patient you might be talking about using if they have like a rheumatic or a immune system disorder along with their IBD. You might choose like a rheumatologic therapy along with an IBD-directed therapy. And then if they have a really poor prognosis, you might think about using combination therapy in them. So you'll say you've selected a patient for this, and what are the things that I think about in choosing the therapy to use or the combination to use? I already talked about the mechanism. I also want to talk about immunogenicity, safety, and then some patient-specific factors that I'll point out. So this one I think is important, and it'll be pretty quick to talk about, but you have your antibody-based therapies which have the potential to cause an immune response to it. Some more than others. Obviously, our anti-TNFs we worry about the most, but in theory, any drug that is based on an antibody, you can have autoantibodies formed to that. And so I think this is particularly salient if you have someone who has prior antibody formation. You want to think about that. If you have a patient you're thinking you might be starting and stopping therapies, and I didn't get into this much because we don't know the answer, but one of the ways you might use combination advanced therapy is you actually start two, but you plan to pull one off, or you plan to use one as like the Band-Aid when they're having a flare. If that's part of your plan, you definitely want to select a small molecule for your second agent because you can stop and start that and not worry about immunogenicity. If you think there's someone that you just got to hit them with something and leave them on it indefinitely, you can choose two that are both antibodies. But that's something I think you want to think about. I'm giving you a lot of think about this, but I don't know the answer. Sorry, that's just kind of where we are with this. But this is what I consider. Safety. Again, I'm not going to go into a ton of details on this because there is a paucity of data, but and the other thing I'll say is when I first started putting this talk together, I was looking at trying to pull out all these safety data about all these different drugs, and I realized it's not really important because when you put these drugs together, it changes the safety profile, and we can guess how they're going to interact, but you can't just say drug A and B had the lowest risk of adverse events, so you put them together, it's going to be the best. That actually doesn't play out in the in the meta-analysis I'll talk about a little bit later, so that's something to consider. But in general, I think about how the anti-integrins probably have the most minimal overlap, the most minimal safety overlap because they've got specificity. These two probably have the biggest compounded safety effects, particularly with infectious etiologies like bacterial infections and fungal infections. But as we'll see later, the overall safety data of the combinations appears to be acceptable. And that's kind of like non-biased, just when you slam a bunch of studies together and do a meta-analysis, kind of indiscriminate of what the combinations were, the safety data appears pretty good. So these are things to think about, but I do think you want to think about the safety profile more in a patient kind of specific manner, and what I mean by that is, the JAK inhibitors, there's the MACE, major adverse cardiovascular event, and the VTE risk. We don't really see this in the data for our IBD patients like they did in the rheumatological literature for patients that were older and had comorbid cardiovascular conditions. But if you're thinking about using one of these in a patient who's older with comorbid cardiovascular conditions, that's going to be a consideration. Again, if they have a history of skin cancer or melanoma like we saw in the prior case, you want to think about that when choosing your therapy. None of these are like slam, you can't use that drug, but you need to think about it. You need to understand what kind of side effects you're compounding and how that is going to affect your individual patient. I kind of already talked about starting with two and then peeling one away as well. So, and the last thing to think about with your patient kind of specific is the cost. These are very expensive. They're very expensive alone, and they become more expensive. So you do have to consider what are your patient's resources, what are the company's resources for the drugs you're thinking about using, as far as do they have good patient assistance programs and so forth, or will the insurance cover it? And these are issues you have to think about as well. All right, so what's been studied? What do we know? This was one of the first good reviews on this. This was by Wasim Ahmed, who used to be with us. We unfortunately is at Cedar now, but he helped me. He helped me a little bit with this talk as well. In his study, he basically did a meta-analysis of about 279 patients on dual biologics or small molecule. I only put this up here to just show, at the bottom here, it shows the combinations that were included. Not all drugs were included as far as combinations. Part of that was, this is 2022, and not all of them were even out yet, or there wasn't data on them. But when you kind of throw this all together, the adverse event rates for all comers, combination therapy in general, about 30%. The significant adverse events was about 8%. really low malignancy risk, and then about 20% of infections. Clinical response and remission were, 60, 70%, and then endoscopic response and remission were 30 to 40. So this is pretty good, I think, when you think about these are patients that have probably failed 1, 2, 3 drugs, and this is about, the best. These numbers are kind of aligned with a lot of the clinical trials and monotherapy for therapy-naive patients. So you can't take this to the bank because this is a heterogeneous study, and it's just network and meta-analysis of a lot of different drugs. But in general, it shows promise. And then this is the newest kind of meta-analysis that's come out, and they had a couple more combinations. They didn't, in this study, they broke it down by combination. But what I want to point out here is you can see no matter what the combination was, it's similar numbers to the last review. So the significant adverse outcomes, you can see, some of them were 0. They go up to about 20%. Clinical remission was in that 50-60 range, and then endoscopic remission was in the 30-40 range. They break it out into each combination, but I'm just kind of back of the head calculation. That's about what those would be if you combine them all together. And I thought the interesting thing about this study was they did try and make comments or observations about specific combinations. I think you need to approach this with extreme caution. But what I wanted to point out here was I mentioned earlier you would think the vedolizumab would be, like the safest. Well, if you look at the highest pooled significant adverse events, vedolizumab was in one of the combinations that had it at 10% with a TNF. 10% it's not prohibitively high, but that's a surprise to me, right? So the bottom line is we don't know. We can't just look at the safety of each one and say this is how they're going to behave together. We don't know. I also don't know if that's a real signal. I mean, there's going to be a different number of patients that were in that group than all the rest of these. In the clinical response remission, they said that the UPA-UST combination or UPA-Entyvio, and I'll say that UST was, I think, the only IL-23 they had here. Just to point, so they didn't have like any IL-23s. They had 100% pooled response, but there was like 2 patients in one of those studies, and there was 17 in the other. So you can't, I don't agree with trying to pull generalized statements about how to use these from a review like this. The big takeaway to me, though, is that 1, we don't know how they're going to behave together. 2, they again showed really similar safety outcomes and efficacy outcomes as like the prior study. They mentioned UST and alpha TNF appeared to be one of the more effective combinations. They say maybe synergistic. That again goes back to we don't know. Maybe these are going to synergize together. I wouldn't take that to the bank, but that probably warrants some sort of prospective study to see if that's the case. And then I already mentioned that they are missing a lot of the agents in this study. So on to the kind of more prospective stuff. There's not much out there. So there's been a study looking at guselkumab and golimumab. This is called the Vega study. And they were not allowed to have prior treatment with IL-23 or TNF, but they could have prior treatment to vedolizumab or tofacitinib. And they could be on some concomitant therapies. This is a phase 2 trial, 214 patients. And this trial actually did not reach statistical significance in its predetermined endpoint. Numerically, the patients on combination therapy compared to guselkumab monotherapy did do better, except for in week 38 clinical improvement. So that's the clinical stuff, and then here's the endoscopic changes. But in this study, the safety profiles were very similar percentages of safety outcomes. Serious infections were expectedly the most reported serious adverse event. In general, it looks like for some of the patients, they did do better on combination therapy. And then, again, this was a little bit different patient population than that necessarily multiple refractory patients because they didn't allow all prior therapies to have been used. This, as far as I know, has only been presented in abstract. I think it was ECHO, but this was looking at vedolizumab and upadacitinib in UC and 61 patients, and they definitely showed a clear improvement in clinical response and endoscopic response when using combination therapy compared to vedolizumab alone. But, and there was numerical difference in remission rates, histologic, endoscopic, and clinical. They did not reach significance, but they were getting there. I don't have safety data from this. Not all the data I don't think is out on this. So that's about it for like the prospective combination advanced therapies that's been studied prospectively. There is a lot in the works. I think there's a study called Victriva that's in the works. And so look for more to come out on this. I think we're gonna have a lot more information in the future. Last thing I'm gonna hit on, bispecific antibodies, trispecific antibodies. So this is potentially like the next new thing. And this is just a table from a review. The ones that seem to be the furthest along on this table is this SOR 102. So this is a antibody that is kind of two-headed, and it hits TNF and IL-23. This was a phase 1 study, so they actually had healthy patients in it as well as UC patients. They were looking at safety and just also seeing if you could get a safety signal from it. And there was similar safety, which is great. And when you look at the numbers, just looking at the UC patients, there seemed to have been some improvement on the drug compared to placebo. It didn't stand out yet. The endoscopic improvement was not super overwhelming, but I think more to come on these agents. I think they might be one of the waves of the future. And then another potential wave of the future with these is, this is kind of two-headed, one using triple therapy. So the Explorer trial is an open-label phase 4 trial looking at triple therapy with vedolizumab, adalimumab, and methotrexate. And it's also been given to biologic-naive patients. So these are two additional things we need to explore. What about triple therapy with 2 advanced therapies and an immunomodulator? It looks like these patients are having a good response. And also almost Sonic-esque, like using this first in biologic-naive patients. This certainly is not, we're very far away from that, but it's something to think about. I don't know if we're ever going to get there, but could top-down therapy in the future mean kind of getting a little more fancy with our combinations? They tried to do some post-hoc analysis and compare it to what like vedo monotherapy or adalimumab monotherapy would be. You can't do that with this kind of open-label phase 4 study, but it's promising nonetheless. So again, these are kind of the things we talked about. My summary, I'm not over yet. Okay, summary. So combination therapy, this is likely to be a key tool going forward in a number of different ways. Selecting which patient to use and which combination to use is very patient dependent. It relies a lot on making educated guesses, using what we know about these drugs. But thus far, I'd say what I feel most confident, I don't feel confident yet saying like which ones are going to work better, which ones aren't going to work as well. But it looks pretty good as far as safety data goes. So it looks like when you put these together, you can do that. I mean, it's not like you put this on patients and they all crash and burn. They have very similar safety rates to our monotherapies. Not to mention leaving someone with terrible inflammation is a safety risk by itself. So I would encourage people to kind of start to feel more comfortable with using these from a safety aspect, but which ones to choose, we just don't know yet. There's a lot of prospective stuff coming out, and look for and even try specific therapies, because I think that's going to be one of the waves of the future. So Ben, I used some of Ben's slides. He helped me out a lot. So I want to say thanks to Ben, and then I mentioned Wasim helped me, and thanks you to John and Mark for inviting me to talk and for listening.
We're going to just, Natasha's going to speak to us next. Natasha, just wait 1 second. We're going to try to adjust the podium just so that you don't have to turn so much. Give us 1 second here. Give you a tough one. It's an exciting topic, and obviously there's a lot to be learned here still, but I think really clinically relevant. Our next speaker, Natasha, is going to take us in a different direction. She's going to be talking about other ways that we can treat our patients, which are also, I think, very important and very interesting to patients, alternative and complementary therapies in IBD. Take it away, Natasha.
Okay. I had asked Kale yesterday not to be as funny as he was last year, so thank you for that. Tough act to follow. Which do I use here? Oh, how do I go back? There we go, okay. So in terms of my topic, I think that this is a topic that many of us actually shy away from. I think we're much more comfortable talking about the positioning of advanced therapies than we are talking or discussing, a herbal product with our patients. And of course, how many of us reflexively have said, oh, there's just not enough data on that supplement or that herb. So I do hope that by the end of this talk that you are a little bit more comfortable and confident with having these conversations with patients, because I think it's going to be very important sort of moving forward. These are the objectives of my talk. I'm going to discuss the prevalence of CAM use, predictors of its use, the importance of having a familiarity with it, and then I'll discuss sort of the current data and literature that we have on some of the most commonly studied CAM therapies. I was looking for a cartoon about CAM, and instead I found this book that for $9.99 online you can buy. I think it's a quasi-children's book, but I'm not entirely sure. So CAM in and of itself, it's a very huge sort of umbrella term that includes this diverse medical and healthcare systems, practices, and products that generally aren't considered a part of our mainstream or conventional healthcare or medicine. It includes such natural products as herbs, vitamins, probiotics, as well as various mind-body practices like yoga and acupuncture and meditation. Obviously, complementary means adjunctive or in addition to conventional medicine, whereas alternative means instead of or in place of traditional healthcare. And integrative medicine is becoming even more popular, and this is where we have traditional providers or physicians that are applying some form of CAM therapy within their practice. And CAM is very important. It's a significant component of global healthcare, and it does necessitate evaluation of its safety and its efficacy. And so, anecdotally, we know that our patients are using CAM, but what does the research actually say? Anywhere from about sort of 50 up to 90% of our patients are using CAM in some form or another, whether it's now or sort of within the past 5 years. And that's within our adult population, but even in our pediatric population, upwards of 84% are using CAM in some way. And obviously this will be influenced by their parents and their peers. And it is important to note that up to about a third of patients are actually using CAM therapy specifically for their IBD, which is why this topic is very important to us. So we know that CAM is popular, but does the popularity and the use in patients, is that actually being reflected in the literature that we have? And the answer is no. Since 2000 to 2020, CAM represented only 1% of all of the publications for IBD. You can compare this to the microbiome, which is about 7%, or any type of diet-related therapy for IBD, which was 6%. And obviously, CAM is very difficult to study. It's a huge umbrella term where there's all these different products and services. There's challenges with standardization and quality control, insufficient preclinical data, and obviously funding for something that's naturally occurring is just not going to be there. There are various predictors of CAM use. I think some of these we probably know or make sense. Female gender, higher income, urban dwelling, and if your social network, your friends or your relatives are using CAM therapies. But also interestingly, so side effects or dissatisfaction with conventional therapies, prolonged use of steroids, and also long-term progression of disease. So that cohort that maybe has more severe disease or sort of poorly managed disease are turning to CAM therapies. So, why should we know about CAM? We already have so much to talk about in our appointments with patients. Why should we be making space for a discussion about CAM therapies? Well, the fact is that even though patients are using it, up to 80% of patients don't actually feel well informed about what they're using. And 75% of these patients are also not disclosing, but do want to talk about it with their CAM or with their healthcare providers or their physicians. And so there really is an opportunity there. There's obviously a safety concern, and more so that individuals who are using CAM, this is associated with a covert dose reduction of their conventional medicine. So they're using CAM therapies and they're potentially lowering their dose of their 5-ASA or not going, when they should for their infusions and whatnot, and that's related to CAM use potentially. Also, CAM use is associated with dissatisfaction with a patient-doctor relationship, as well as poor physician communication. And symptoms that are typically associated with disease activity are cited as the reasons why people are seeking CAM. So does this reflect sort of suboptimal treatment or efficacy of our conventional therapies? Does this represent maybe coexisting conditions that we're not adequately sort of treating or addressing? That's potential. This is a list of the potentially used CAM that I'm going to discuss. So cannabis, it's one of the most important ones we need to discuss. This is just sort of a schematic map that shows the access that Americans have to marijuana. You can see the green states, they have access to it for medical purposes. It seems like the indications for medical purposes are increasing almost daily rate. And then all of the orange states are ones where you can also access it recreationally. Back in 2013, Jessica Allegretti did one of the first surveys looking at cannabis use in IBD patients, and she found that about 12% of patients were using cannabis. This was in 2013, and I think this was right after legalization in Colorado or Washington. This was before federal legalization in Canada, which happened in 2016. And so then fast forward about 10 years, and now you have up to 37% of IBD patients are saying that they're using cannabis. And 63% of them are saying they're actually using it for their IBD, not just recreationally or for other purposes. And again, the majority of them are reporting that when they're using it for IBD, they're using it for their abdominal pain, cramping, and diarrhea. This was an earlier study that looked at patients with IBD using cannabis and found that those who were using it primarily for relief of their IBD symptoms were using it much more frequently than those that weren't using it for symptom relief. And they were also had a significantly higher rate of abdominal surgery, chronic analgesic use, as well as other forms of CAM use. So cannabis contains nearly 500 chemicals. The most well-known are THC, which gives you sort of that high or has that psychotropic effect, and then CBD, which has these sort of anti-inflammatory, potentially immunomodulator effects. And really the basis of cannabis, potentially for IBD and other GI conditions, is related to the endogenous endocannabinoid system, which is linked to visceral pain, perception, nausea, motility, and inflammation. This is a schematic diagram that just demonstrates where our cannabinoid receptors are within our colon. We do have our CB1 receptors that are located within the epithelial cells, the intrinsic and extrinsic neurons, as well as vagal affect neurons. And then our CB2 receptors are located within our epithelial cells and more so in our immune cells, so our neutrophils, activated macrophages, and subsets of T and B cells. And then we do have some animal models that show potential therapeutic targets for cannabinoids. CB1 and CB2, the receptors, those are upregulated when there's inflammation, and stimulation of that actually helps to attenuate inflammation. And this can be done by our endogenous cannabinoids, which are derived from these phospholipid layers that contain arachidonic acid. And so in terms of the efficacy in terms of the efficacy of cannabis used for IBD, there was this recent meta-analysis just last year that evaluated the clinical symptoms or activity index in patients with Crohn's disease. They had moderate to severe Crohn's disease, had failed some form of conventional medicine, but were stable on either an immunomodulator, a steroid, or a biologic. And it found that there was no difference between the treatment group who were going to take cannabinoids versus placebos before therapy, but then after therapy, so after cannabinoid use, there was significant improvement in symptoms or clinical activity index. Now, when looking more at endoscopic activity, however, there was 2 studies that were included, and it found that there was no difference in the endoscopic inflammation that they found after therapy with cannabinoids between the treatment group and the placebo group. And the treatment group had an SDS-CD score median of about 10, and the placebo group, it was about 7, so it's comparable there. The same meta-analysis also looked at ulcerative colitis. It just looked at symptoms using the Leichteger score and found that before and after treatment with cannabis, there was no statistical significant difference. There were secondary outcomes that were looked at in the meta-analysis. Quality of life was evaluated, and it did show that among all IBD patients, there was improvement in quality of life. And this was observed both in UC as well as Crohn's disease separately. But then for our biochemical markers, our objective markers, it looked at CRP, and there was no difference amongst the Crohn's disease group. Interestingly, the UC group, they had lower CRP levels both before cannabis therapy and after cannabis therapy, so there was really no benefit there. And then similarly for fecal calprotectin, there was no statistical difference before and after intervention with cannabis. And of course, there was substantial sort of heterogeneity amongst all of these studies. I think we know there's a lot of adverse events, and so just overall with cannabis, you can have sleepiness, nausea, poor concentration, dizziness, a ton of different side effects that are associated with it. There's also more serious side effects, potential addiction to marijuana, other substances, impairment in mental health, as well as brain development. But there's also specific adverse events related to patients with IBD. And so for those with Crohn's disease who are using cannabis, we do see a higher rate of corticosteroid use, higher rate of ED visits, as well as hospitalizations, and higher use of opiates. And then for the patients with UC, we are seeing a higher rate of ED visits and and hospitalizations as well. And so to conclude on cannabis, it is associated with an improved quality of life for both Crohn's disease and UC, and there is an improvement in your clinical disease activity index for Crohn's disease, but not UC. It doesn't improve our biochemical or objective markers. It doesn't improve any endoscopic outcomes, and there is a higher proportion of adverse events associated with cannabis use in our IBD patients. And so, the potential clinical benefit must be weighed with this lack of effect on our objective disease targets, as well as considerable adverse events. Next, I'll talk about turmeric and its bioactive component or compound curcumin. This is one of the most well-studied herbs for IBD. It's a staple spice in Asian cuisine. It's been used for thousands of years medicinally and has certainly gained attention more recently for its anti-inflammatory effects. There are a few animal models that do demonstrate potential sort of therapeutic targets and mechanisms whereby these animal models of colitis, when given curcumin, it does show reduced infiltration of these CD4 positive T cells, reduction or inhibition of NF-kappa B, as well as a reduction in histologic inflammation and your MPO activity, which is a marker of neutrophil activity. A meta-analysis in 2022 came out looking at curcumin used in UC. There really is no data on its use in Crohn's disease, so all of what I'm going to present is for UC. And so this was a meta-analysis of 6 RCTs. These were patients that had mild to moderate UC that were receiving some form of standard care with 5-ASA, either oral or rectally. And when it compared those given curcumin with placebo, it did find that the adjuvant curcumin was effective in inducing clinical remission with a risk ratio of 2.1. And however, when looking at endoscopic outcomes, there was sort of a numeric signal that did favor endoscopic response in the curcumin group. However, there was no statistically significant improvement with the endoscopic response or in endoscopic remission in the patients that were given curcumin compared to placebo. Within this meta-analysis, and as I mentioned, CAM is very difficult to study, and this is for multiple reasons, but you do get this heterogeneity amongst the studies. And so within this, there was multiple different types of doses that were being used, anywhere from 450 up to 3 grams of curcumin. They did find that greater than 500 milligrams was associated with clinical response and remission. There was also many different forms. One study used a rectal enema of curcumin, which was found to be superior to placebo for clinical remission, improvement in endoscopic remission. I don't know how many patients would want to use curcumin as an enema, just given, we all know it has that very distinct color to it. There was different duration of treatment within these studies as well. They ranged anywhere from 4 weeks up to 6 months. They did find the longer you were on it, so it was better at 3 months for clinical remission and improvement compared to 6 weeks. There is a concern about blinding. As I mentioned, there's a very distinct color and taste with curcumin, so actually sort of getting a true placebo is very difficult in these studies. There's no real sort of serious adverse events that were found related to curcumin, but there is sort of some minor adverse events, some GI upset, hot flashes, hypertension. There's one study that looks at actually maintenance of remission, very, very early study back in 2006 of 89 patients with mild to moderate UC. They were either on sulfasalazine or 5-ASA, and they received 2 grams of curcumin. And the relapse rate as defined by the Rach-Milovitz indexes was evaluated. They did find that there was statistically significant improvement, both clinically as well as endoscopically, with the curcumin group at 6 months, but that wasn't a durable response. So at 12 months, there was no difference between placebo and curcumin. And this leads me to a commercially available product that I think has gained a lot more attention over the past couple of years. It's known as CurQ-D. This is a formulation of both curcumin at 1.5 grams per day, and then also an Asian herb known as Qing Dai, which I'll talk about briefly, also at a dose of 1.5 grams per day. And so Back in 2024, the study came out. It's a placebo-controlled RCT of 42 patients. It looked at 8-week induction trial followed by an additional 8 weeks of maintenance for those that responded. Patients had mild to moderate UC. They could be on concomitant medications, so this included biologics, immunomodulators, 5-ASA, but they had to be on a stable maintenance dose of that for a minimum of 4 to 12 weeks before they were in the study. And steroids were allowed, but not high-dose steroids. And so before I get into the data, just wanted to discuss briefly Qing Dai. It's also known as Indigo naturalis. So this is a herb commonly used in traditional Chinese medicine. It's used for chronic diseases such as psoriasis because it's purported to have these anti-inflammatory effects, antipyretic effects, and antimicrobial properties. There are some animal models that suggest that the mechanism by which this occurs in terms of helping with colitis is via this activation of this aryl hydrocarbon receptor. So looking at the 8-week induction trial, the primary outcome was a combination of clinical, biochemical, and endoscopic response. And it did find that there was a statistically significant improvement in the group that was taking KIR-QD compared to placebo. And then in terms of the secondary outcomes, more specifically the clinical remission, clinical response, and endoscopic improvement, there was also statistically significant improvement in the KIR-QT group compared to placebo, but we did not see that, or that wasn't seen with the fecal calprotectin response. And I didn't show it here, but at 4 weeks, there was a significant reduction in patient-reported rectal bleeding. For the maintenance arm of the trial, the 15 patients that did respond to the curcumin entered this maintenance arm, and then or did respond to the KIR-QD, excuse me. They entered into the maintenance arm and received curcumin alone from weeks 8 to 16. At week 16, 14 of the patients maintained clinical response, and 11 maintained clinical remission. Of course, this study wasn't properly powered, a very small sample size, so they couldn't detect differences in other sort of objective measures or outcomes. And the potential mechanism for KIR-QD and curcumin. So as I mentioned previously with Qing Dai, it does upregulate the aryl hydrocarbon receptor. Following activation of that receptor, you do get this upregulation of your CYP1A1. And this study found that those individuals given KIR-QD, they did have an upregulation of the CYP1A1 in the rectal mucosa. And this was increased from baseline to week 8. And this upregulation was even more numerically pronounced in those that responded to the KIR-QD versus those that did not. In terms of safety, very, very comparable safety to placebo. Most common adverse events include headache and elevated liver enzymes. Higher doses of Qing Dai are associated with a rare development of pulmonary arterial hypertension, and that is the reason why the maintenance trial didn't include Qing Dai in it and just included the curcumin alone. And so to conclude on curcumin, I think this can be considered as an adjunctive induction therapy for mild to moderate UC in those that haven't had optimal response to 5-ASA, and can also be considered for patients in remission as a supplementary therapy with 5-ASA. And the effective dose is between 1 to 3 grams per day. So fish oil is one of the most common CAM therapies that our patients are on, not necessarily for IBD. When we're talking about fish oils in terms of medical therapy, we're really talking about omega-3s, so your EPA and your DHA. These are known to inhibit arachidonic acid metabolism, and so that's where you get sort of this anti-inflammatory effect. The first studies on fish oils that were done in IBD patients were way back in 2008. There were 2 studies known as the EPIC trials that looked at giving patients with Crohn's disease 4 grams of omega-3 fatty acids, and then looked at their rate of clinical remission at 52 and 58 weeks, looked at their rate of relapse and found that there was no difference in rate of relapse between those on the fish oils compared to those just taking placebo. And it's important to note that EPIC 2 trial, it did include patients that were on steroids. A few years after that, there was a meta-analysis that came out that looked at both Crohn's disease as well as ulcerative colitis. And so in the 6 studies of Crohn's disease, when compared to placebo, the omega-3 fatty acid group did achieve a statistically significant reduction in the risk of relapse after a year. However, with the 3 UC trials, there was no statistically significant reduction in relapse. There are issues with compliance with fish oils, just because side effects with it include sort of unpleasant taste, this halitosis that you can have, GI upset with heartburn, nausea, and then some diarrhea. Now, fast forward to more recently, back in 2024, there was a UK Biobank prospective cohort study of over 250,000 people that did see that individuals who consumed oily fish at 1 serving per week, and oily fish is the ones where you get the higher omega-3 content, that this was associated with a 19% lower risk of developing IBD. And then those individuals that took a fish oil supplement, this was associated with a 16% lower IBD risk, and there was no significant associations for non-oily fish. And so oily fish are things like, you know, your tunas and salmons and such. And so I think despite this recent data, you know, there is insufficient evidence to recommend fish oils to reduce the risk of IBD or for treatment, but I certainly have no problem if my patients want to take it. Probiotics are also a very common CAM therapy used. And so there was a meta-analysis in 2024 that looked at Crohn's disease and found that for induction of clinical remission as well as endoscopic remission, which included 4 RCTs in total, there was no evidence of benefit compared to placebo. And then when looking at maintenance, for both clinical recurrence as well as endoscopic recurrence, and clinical recurrence, this included RCTs of patients without surgery, but also patients that had had an ileocolic resection, and found that, again, there was no evidence of benefit when compared to placebo. Obviously, with these studies, major issues with them in terms of, you know, they're using different probiotic strains, there was different inclusion criteria, concurrent treatment, as well as the comparators. In terms of ulcerative colitis, there was a Cochrane review back in 2020 that found that probiotics may induce clinical remission in patients with UC compared to placebo. There was no difference between probiotics and those taking 5-ASA, and this was concluded as being, you know, low certainty of evidence. That same meta-analysis that I spoke about in terms of Crohn's disease also looked at UC, and did find that for induction of clinical remission, that there was statistically significant improvement for patients on probiotics compared to placebo. And they also did a subgroup analysis and found that there was a potential benefit when the probiotics were combined with 5-ASA for clinical remission. And then with maintenance, again, compared to placebo, there was benefit with probiotics. However, again, a subgroup analysis, it didn't show that ongoing addition of probiotics to 5-ASA was any better. Now, there is this 8-strain probiotic combination that I think we're all sort of very familiar with in many ways. In terms of the literature behind it, so for UC, there is a higher rate of remission as well as a lower relapse rate. But in Crohn's disease, there isn't found to be any benefit in inducing remission of active Crohn's disease or preventing relapse of quiescent disease or preventing relapse after surgical induced remission. This is in contrast to the results related to pouchitis, which does show significantly decreased odds of relapsing pouchitis, and then there's maybe possible benefit of preventing an initial episode of pouchitis. These are other treatments that might come up in your discussions with patients. Very little minimal data on them, but I'll just sort of briefly touch on it. So Andrographis paniculata is a herb. And there was a study of about 245 people that did find that it was superior to placebo in inducing remission and response in patients with ulcerative colitis. The other herb, Boswellia serrata, this is Indian frankincense. In 2 studies was found to be just as effective as sulfasalazine or 5-ASA for IBD in general. And then Artemisia absinthium, there were 2 studies in Crohn's disease that showed it was superior to placebo in inducing remission over a period of 2 to 10 weeks. Artemisia is common wormwood, I believe. And then aloe vera, this was superior to placebo in inducing remission or response in UC. And then one of the mind-body techniques that I think, we are gaining sort of more knowledge in, and many patients are using it for various sort of ailments, is acupuncture. There was this network meta-analysis just recently that showed it was superior to oral sulfasalazine for just, all comers for IBD. And it was ranked highest among the non-pharmacologic interventions for clinical remission as well as symptom relief. And this is just my last slide. These are resources. I think it's very helpful for us to have these in the back of our pocket. ECHO does have a fantastic topical review that came out just in 2023 on various complementary and alternative medicines in IBD. There's also a series of databases that you can go to, which will show the literature on various herbal products and natural supplements, and can even look at for various herb and drug interactions as well. And that's the end of my talk. Thank you.
Thank you, Natasha. Next, we're going to have Frank Scott from Colorado talking to us about guidelines and more guidelines, how to discriminate. Take it away, Frank.
Thank you, Mark. It's really great seeing so many faces this morning. It's a really exciting to see this conference grow over the last couple of years. It's really awesome. I can promise in this relatively dry presentation that we will have no hand-drawn monoclonal antibodies or small molecules. And unfortunately, I won't be talking about any CAM-related therapies either. Mark had tasked me with reviewing some of the recent guidelines that have come out from both the ACG and the AGA, and I do want to highlight just that I am significantly conflicted here in that I sit on the AGA side of the fence. But I don't think that there is a right approach. They're just a little different, and my goal is really to highlight how they are a little different, and then also talk just a little bit about where there's overlap and highlight some of those unique differences. So our learning objectives, like I said, will be to discuss the different structures of the AGA and the ACG guidelines for inflammatory bowel disease, review a little bit on how each society formulates those guidelines, what's similar, what's different. Then I'll compare and contrast 3 areas of overlap: disease activity monitoring, particularly biochemical monitoring, the pharmacologic recommendations with regards to Crohn's, and the pharmacologic recommendations with regards to UC. And then I'm going to hop across the pond and place them in context of what BSG and ECHO also recommended, because as if there wasn't enough guidelines in the last 2 years, they also came out with new guidelines as well. For those that aren't aware, these are the 6 IBD-related guidelines that have been published by the American College of Gastroenterology and the American Gastroenterological Association in the last 2 years. On the AGA side of the fence, we have Dr. Barnes and his excellent guideline with regards to pouchitis. And then we have both medical management of moderate to severe UC and the medical management of moderate to severe Crohn's disease. And then on the ACG side of the fence, we have more comprehensive guidelines with regards to the management of Crohn's and UC, and then preventative care and inflammatory bowel disease by Frank Ferret and colleagues. There are a lot of similarities in how the 2 societies approach their guideline formulation, and they both sort of the foundation for the ACG and AGA are both grade related. And for those that aren't familiar with what grade is, it's a sort of structured approach to guideline development. And it really starts with on the left here with defining your team, your guideline group membership, and then deriving from that a specific guideline panel that's going to review the questions that are of interest. They then look at specific question generation, determine what topics they want to address, what's related to the specific guideline of interest. They summarize the available evidence after a careful discussion with regards to what effects are interested, what outcomes they're interested in focusing on, and what the adverse events may be. They then review the literature, judge the body of evidence amongst the panel, and then formulate very carefully recommendations and strengths thereof. You'll often see a statement like, we recommend the use of drug X, and this is a strong recommendation with weak evidence, and that's sort of what this is related to. There are equations that help you get here. This is not just us making this up. It's a structured process. And then you develop a report. This usually has some period of open review where the public can comment on it, and then it's disseminated and implemented. And then there's usually some formulation with regards to how we update these recommendations. And that's a little bit different from each guideline, which we'll talk about in a second. The PICO framework is what we use to determine what questions matter. And this is just an example of what PICO looks like. It's an acronym, as one would suggest, by the all capitals. It's the patient population, intervention, comparator, and outcome. And as just an example, patient population could be moderate to severe Crohn's disease, and you're very interested in looking at risankizumab. And the comparators could be placebo, but could also be ustekinumab, because one of their studies had an active comparator. And you could also look at multiple outcomes, like steroid-free clinical remission, endoscopic remission, and clinical response. And there is some variability with regards to societal preferences for these. For example, AGA puts a strong preference on steroid-free clinical remission because we believe it is a very patient-centered outcome that's routinely reported that allows for comparison across studies. Whereas the ACG also emphasizes endoscopic remission in their recommendations, whereas the AGA felt that there's still a knowledge gap with regards to whether or not that should be an appropriate target. There are differences in structural approaches in how the two societies view their guidelines, and I just want to highlight that on the right side we have the ACG's guidelines. You can see there's one large sort of opus with regards to the management of Crohn's disease in adults. It's very thorough. It goes through epidemiology of disease, talks about mild disease management, then heads into moderate to severe disease management, et cetera. And same thing with ulcerative colitis. They took a similar approach, whereas the AGA, and I don't think that there is a right approach here. I think that both of these are viable, sort of breaks it up into different pieces. Biochemical assessment and biomarkers, and then this is a little bit more older guideline that I included because it still includes perianal fistulizing disease, whereas in our most recent update, we really focused on the medical management of moderate to severe Crohn's and didn't touch on perianal disease in the update. Similarly, for ulcerative colitis, the AGA focused on biomarkers and then medication management as opposed to having one single document. And then there are areas where there is no overlap. There's the pouchitis guidelines from the AGA. There is no ACG equivalent at this time. And then there's the really awesome preventative care guideline from Frank Ferre by the ACG, for which the AGA has no equivalent. So when I compare and contrast here, I'm going to focus on areas where there is overlap, so you can just see a little bit of the difference. There's also differences in how we come to our recommendations that I think it's really important to recognize. The ACG employs direct head-to-head evidence, and they are actually kind of strongly opposed to the use of meta-analyses or network meta-analyses for the generation of recommendations. They're not necessarily opposed to the methods themselves, but that they should be hypothesis generating, not guideline generating. Whereas the AGA will use those data in all of their guidelines to perform meta-analyses and network meta-analyses. As a Markov modeler, somebody who's familiar with in silico analyses, I'm very comfortable with this approach, but I can understand why the ACG takes the approach that it does. They also both provide recommendations that are not evidence-based or derived from the literature, but sort of eminence or expert-based. And these come in two different forms. In the ACG, these are key concepts. In the AGA, these are noted as implementation considerations, things that the panel says should be parts of routine care, but there is not necessarily a clinical trial to prove that they should be. It's just stuff that we all think is standard. And then lastly, the ACG is still employing a traditional periodic update. As an example, this would be a 4 to 5 year cadence for updating your guidelines, whereas the AGA has moved at least their pharmacologic guidelines to a living approach, which allows us to re-review the literature every 3 to 4 months and then update the guidelines on the fly without having to go through the entire process of revising the entire guideline. We can say, there's a new drug in the category X, and so we're going to add that to the guideline on an iterative basis as opposed to an entire revision. For those that aren't familiar with meta-analyses and network meta-analyses, I just wanted to provide a quick review of where they're used. Meta-analyses are sort of traditional forest plots, looking at rates of response and non-response across trials and then combining them. These are used in pouchitis guidelines, in the biomarker guidelines for both UC and Crohn's disease. Network meta-analyses are when we use placebo-based standardization of effect estimates to try to cross-compare therapies that weren't directly cross-compared in the trials themselves. So it's a more sort of synthetic approach to try to compare drugs, and it's based on these NMAs that the AGA derives primarily their medication positioning statements. So diving right in, and this is a live action shot of Dr. Lucan crushing that deep pow yesterday. It was so awesome out there. Disease activity monitoring in Crohn's disease and UC. And from here on out, I apologize, it's going to be tables on tables. We're looking at both UC and Crohn's in the AGA. They do recommend that we combine biomarkers and symptoms, which, as we heard earlier, that this is part of treat to target care. We shouldn't just be asking how patients they feel, how they feel, but we should be assessing CalPROs and CRPs too. And the AGA goes so far as to recommend cutoffs for fecal CalPRO of 150 if patients are in remission or if they have active disease. And if it's elevated, that we consider endoscopic assessment. What's interesting is that the AGA for people who have moderate to severe disease activity actually say that you can go ahead and just avoid endoscopy and make treatment modifications based on the biomarker alone. And I think, personally, I probably lean in this camp, but I still usually will pursue a scope or imaging to confirm structural evaluations as well, whereas they go so far as to say like the biomarker alone is enough. In mild symptoms, conversely, they say that regardless of what the biomarkers show, you should be thinking about a structural evaluation. So you could see how that could lead to some over and underutilization in both directions. And then for postoperative monitoring, they recommend a more stringent cutoff. We know that fecal CalPRO levels tend to be a little bit lower in small bowel disease, but still may signify active disease, and so they recommend this cutoff of less than 50 for patients who are considered low risk, who haven't failed multiple therapies, had surgery in the past, other high-risk features, versus those that are higher risk that you just use endoscopic monitoring. The ACG, on the other hand, does not recommend specific cutoffs. They do say use CalPRO, it's pretty cool. But they don't say, here you should target less than 150 or whatever. They, in fact, identify in the text that the cutoff itself is a knowledge gap. And so that's one important thing to recognize is that they don't think that we have a good cutoff and that you should put that in the context of the patient holistically. They also add some key concept language to their recommendations, particularly in Crohn's disease, things that we think are standard of care that you should be ruling out infection as well, and to identify potential pathogens that could also cause a false positive fecal CalPRO. Mucosal healing is very different in both guidelines. The ACG has taken a very forward approach and said that we should be targeting endoscopic improvement, which they define as Mayo 0-1 in UC, or the healing of ulcers in Crohn's disease. Whereas the AGA, we identified that we do not think that there is enough data to make that recommendation in Crohn's disease, and in the ulcerative colitis guideline, we didn't even address it actually. So we think that there may still be additional studies that are required that say that patients definitively, when thinking about symptomatic remission, do better when you're targeting mucosal healing. For the management of mild Crohn's disease, the ACG recommends against oral mesalamine for induction or maintenance. They recommend ileal-release budesonide for induction of remission, and they recommend against ileal-release budesonide for maintenance. The AGA actually doesn't have an active guideline at this time for mild Crohn's. The more recent guidelines focused on moderate to severe disease. The 2021 guidelines by Joel Feuerstein focused on moderate, severe, and perianal disease, but they do not have specific recommendations with regards to mild disease. And in fact, in our moderate to severe guidelines, we explicitly say these guidelines should not be applied in mild disease unless they've had other high-risk features or failed therapies, et cetera. For moderate to severely active Crohn's disease, the AGA recommends early use of advanced therapy over step-up therapy, and this is an explicit recommendation based on the review of 3 studies. The strongest evidence was the more recent profile study, which I'm sure many of you are familiar with. The ACG comments on it, but does not make an explicit recommendation. They say at multiple points in their document that you should consider it, but it's not one of their sort of in their table recommendations. And with regards to immunomodulators, very similar recommendations with regards to induction. We should not be using immunomodulators, particularly thiopurines, for induction anymore, but they're okay for maintenance. And sub-Q and IM methotrexate is okay for induction and maintenance as well as PO, but the ACG does not make a recommendation. With regards to advanced therapies, the ACG takes like a very blanket approach. They looked at each drug, compared it to placebo, and came up with recommendations for induction and maintenance. And you can see across the board, all the therapies that we think are viable therapies in Crohn's disease were recommended. All of our anti-TNFs that are FDA approved, vedolizumab, ustekinumab, risankizumab, mirikizumab, guselkumab, and upadacitinib. They did specify that this required prior anti-TNF exposure, and that had to do with the sort of current FDA labeling. They did make one positioning recommendation, and that is that the risankizumab could be used in preference over ustekinumab, and that's because they based their guidelines on the presence of head-to-head data, and we have head-to-head data showing that risankizumab is superior. The AGA takes a little bit of a different approach. We do the same thing up front. So we say, we recommend the use of infliximab, adalimumab, ustekinumab, risankizumab. You think these roll off my tongue faster after doing this for 10 years. Guselkumab, upadacitinib over no treatment. And then we suggest the use of certolizumab or vedolizumab over no treatment. These are in placebo comparison. But then we want to step further, and we use those network meta-analytic data to come up with positioning statements too. And this is where we diverge. We created buckets of efficacy. We had higher efficacy and lower efficacy for those that were treatment naive. And then we took the stratified data from clinical trials with regards to prior advanced therapy exposure. And it's important to recognize that the caveat here is that prior advanced therapy exposure is almost always infliximab. And we created higher, intermediate, and lower efficacy buckets because we wanted to generate a little bit of controversy with regards to how these medications should be positioned. So for the higher and lower efficacy buckets in treatment-naive individuals, infliximab, adalimumab, vedolizumab, ustekinumab, risankizumab, mirikizumab, and guselkumab were considered higher efficacy, whereas certolizumab and, to the consternation of many, upadacitinib were considered lower efficacy therapies, and I just want to speak on that for 1 second. It's important to recognize that, one, we were able to initially hide behind that sort of FDA labeling that you needed to fail a prior advanced therapy before using an advanced therapy when we constructed these guidelines, but that's gone now. But the second issue in Crohn's disease in particular is that it does appear that upadacitinib, if you go back to the clinical trials, has disease location specificity. And if you look at all comers in Crohn's disease, many of whom have ileal disease, upadacitinib does not appear to be that effective in the clinical trial data that's published thus far for ileal disease. And Sid Singh, who is the senior author on this guideline, has a really awesome other meta-analysis that was recently published this year that I encourage you to check out that did stratified analyses of upadacitinib based on disease location, and the effect estimate was essentially 1 for upadacitinib in small bowel disease, isolated small bowel disease. So I think there's more research that needs to be done in this space, but there may be some disease location specificity that drove this recommendation. And it's based on the NMA. We weren't just sort of making it up. With regards to prior exposure, go back. There we go. For prior exposure, higher efficacy or intermediate efficacy therapies were okay. And these were felt to be adalimumab, risankizumab, guselkumab, upadacitinib, ustekinumab or mirikizumab. And then the lower efficacy therapies were certolizumab and vedolizumab, which, based on the clinical trial data, makes sense. With regards to combination therapy, and this is not Kale-Steiner combination therapy, but traditional anti-TNF plus immunomodulator combination therapy, both guidelines recommended using with infliximab an immunomodulator, particularly a thiopurine. The AGA said that there were significant knowledge gaps with regards to the use of methotrexate. The literature are kind of old at this point and very heterogeneous. And we don't know as much about adalimumab combination therapy, nor do we have data supporting non-TNF biologic therapy in combination with an immunomodulator as well. Whereas the ACG provided a more inclusive statement as opposed to parsing it out by drug. They just said azathioprine 6-MP or methotrexate may be used in treatment of active CD as adjunctive therapies for reducing immunogenicity. So it's a little bit more inclusive. The AGA also explicitly recommended immunomodulator withdrawal. And that concept means 6 months after starting somebody on combination therapy, if they've had a robust clinical response, biochemical normalization, structural improvement, they have robust therapeutic drug levels, you could consider stopping the immunomodulator, seeing how they do to reduce the risk of the combination therapy. ACG does not comment on that. Perianal Crohn's disease, like I said, the most recent Crohn's disease guideline does not comment on this. And so all of these are from 2021 from the AGA side, whereas the ACG guidelines from 2025 did have a section on this. Both guidelines recommended infliximab. Both guidelines suggested combining biologic therapy and antibiotics. Interestingly, the ACG said for simple fistulas they could be monotherapy, the antibiotics, whereas the AGA recommended it against just antibiotics. ACG, being a more modern guideline, recommended the use of upadacitinib, whereas in 2021 that was not an FDA-approved or even published studied therapy yet. And then both recommended that sort of a team-based approach with regards to incorporating our colorectal surgeons, exam under anesthesia, and CTOM placement were important. With regards to the management of mild, you see a lot of similarities. The most recent, again, AGA guidelines do not comment on this, so these are going back to 2019 now. So we're now, 7 years old. They both recommend the use of 5-ASAs. They recommend the use of budesonide, although the AGA positions the 5-ASA over budesonide. They have a little bit of difference with regards to dosing, whereas the AGA recommends escalating to higher dosing, where the ACG actually comments that both dose levels may be equivalent. After somebody has failed, the ACG recommends changing a 5-ASA class and then moving to a different drug class, whereas the AGA recommends optimization by adding rectal therapy, which we talked about a little bit earlier. And then both comment on FMT, probiotics, et cetera, as current knowledge gaps that for new clinical trial data are required for. Moving on to moderate to severe ulcerative colitis, very similar guidelines, recommendations for immunomodulators. Don't use them for induction. You can use thiopurines as a maintenance agent if required. And then the ACG for your advanced therapies took a very similar approach as they did in their Crohn's guidelines, with strong recommendations across the board for all of our therapies. Now you can see here on the bottom we've added TOFA and we've added the SM1Ps, which have UC indications but don't have Crohn's disease indications. They did make one positioning statement in that we have clinical trial data suggesting that vedolizumab is superior to adalimumab, so they did recommend that, again, sort of following that approach of there are data in a clinical trial format to make this recommendation, so we will. The AGA, again, took a similar approach as they did with the Crohn's disease guidelines, sort of creating these buckets. Overall, they recommended that infliximab, golimumab, vedolizumab, tofacitinib, upadacitinib, ustekinumab, risankizumab, ozanimod, and etrasimod. That went smoother. Were strongly recommended, whereas they suggested the use of adalimumab, mirikizumab, or filgotinib against placebo. And then when considering advanced therapy naive individuals, we created 3 buckets: higher, intermediate, and lower efficacy, and did the same for advanced therapy exposed individuals. And the only lower efficacy medication in the treatment naive group was adalimumab. Everything else, again, intermediate or higher efficacy are fine. They're in different tiers just based on NMA rules, not because we think they're different, and we specify that. So all these other drugs are fine. And then in the treatment exposed individuals, we recommend that the adalimumab, vedolizumab, ozanimod, and etrasimod are lower efficacy medications. So that's just a brief summary of where there are areas of overlap. And I want to highlight again that pouchitis, there's an entire AGA guideline, which I didn't touch on because we have Dr. Barnes here, and that he'll review this evening. And the ACG has an entire really awesome healthcare maintenance guideline. There's no overlap there. There's no equivalent, so I can't compare them. Moving across to the European guidelines, again, there's a lot more similarities than there are differences, but the differences that do exist are that upadacitinib is recommended regardless of therapy positioning. In Europe, since the get-go, JAKs have not required this anti-TNF step-through that we used to require here in the United States. The BSG recommends against immunomodulator monotherapy in toto, even for maintenance. They made no recommendation related to mirikizumab, which is mostly related to when their guidelines were developed. They did not provide recommendations related to therapy positioning or endoscopic targets of recommendation. They didn't say that there was a knowledge gap. They didn't recommend it. They just didn't comment on it. And they did recommend for de-escalation, as the AGA does. And you see the BSG supported filgotinib, tofacitinib, and upadacitinib in any position. Remember, filgotinib is not FDA approved here in the United States. The ECHO guidelines only recommended tofacitinib. They didn't comment on UPA, which is just in relation to when they were published. And then ECHO also suggested vedo over ADA as the ACG does, whereas the BSG does not make that positioning comment. So in summary, the ACG and AGA take slightly different approaches to how they form their guidelines. You know, the AGA, like I said, is much more comfortable with regards to how we use synthesized data, whereas the ACG takes a much more hard line. If it's not a published randomized controlled trial, we can't use it approach. There are structural differences in how the guidelines are built, so that creates some gaps in the topics that are covered. Where both societies provide recommendations, there is considerable agreement. And I think the take-home point here, as a clinician on the front line, is that if I feel that the right one therapy is appropriate for a patient, that I probably have a guideline that supports it. And if I don't, then maybe I shouldn't be doing that. And then there are key differences related to medication positioning and moderate to severely active Crohn's and UC to consider as well. Thank you for your time, and I look forward to questions on the panel.
Thanks, Frank. Tough topic. You nailed it. I really just gave you that because I wanted to see how many times you could say all the drug names without flubbing it, and you nailed it. So good job. Now we're going to have one of our first guest speakers. We have 2 eminent speakers with us today. One is Ed Barnes from University of North Carolina, who's going to be speaking this afternoon. And then Dana Lucan from Cornell is going to be speaking to us on new and emerging therapies in IBD. I want to thank both you guys for coming. I know I really had to twist your arms to come up to Sun Valley, so my apologies. Thanks for coming. Dana.
All right, I don't know if my body will twist, but I want to thank the organizers for inviting me, and it's a pleasure to get the opportunity to both speak and to ski with you. Secondly, for not having stairs before the podium, because I can't get up them today. But you got to send me that picture of me skiing yesterday, because it was spot on, spot on. Oh, okay, I'm doing this one. I thought I was doing the other one. So right now, we're going to talk about the new and emerging therapies in IBD, if I can figure out how this works here. I think I turned it off here. All right, green button. There we go. The big one with the advanced. Here are my disclosures. So we've heard a lot about, how the guidelines incorporate some of our existing therapies. We've heard about, new and innovative ways to use them, how to optimize them. This is just a summary of everything to date that's been FDA approved, but to the right of this are a myriad number of therapies. And so we can see we have our most newly approved therapies are the IL-23s, but there are many more in development, and I think that some of them are very promising and warrant discussion. So this was also said, I think, in Dr. Johnson's talk that there are, therapy ceiling effects of the current therapies. And so with our highest effect size we saw in ulcerative colitis was really in infliximab, right, where there's this 30% effect size for clinical remission, but really nothing has really raised that bar. And so no matter which approved therapy, they're all significantly better than placebo. We haven't actually been able to really get this crushing efficacy. This may be due to when we're using our therapies, this may be how we're using them, how we're selecting the patients, but there certainly is, we're leaving a lot of potential efficacy on the table. And so again, I won't attempt to draw this, but just to show you that it is busy. IBD is busy. There are so many potential pathways that are involved in our therapeutic approaches. And many of these pathways we've targeted with approved therapies. Many have been investigated unsuccessfully, and several are in the pipeline to develop novel therapies. And so I'm going to focus on one approved class of therapies because I noticed that none of the other speakers really went into a deep dive of them, the IL-23s. And then we'll go into two. The other ones weren't necessarily, I'll talk about a few that weren't included on this diagram. Actually, believe it or not, there are more. But we'll talk a lot about the TL1A and then some of the oral formulations, both for IL-23 and for the alpha-4 beta-7. And so starting with IL-23 antagonists, we have heard a little bit about this mechanism. And believe it or not, when you make these talks, you're like, oh, there must be these diagrams readily available. They're really hard to find, but this one I found was sort of a very good representation. And so when you have antigenic stimulation, which leads to activation of your macrophages, dendritic cells, IL-23 is upregulated, right? And the IL-23 receptor is paired with the JAKs and TICs that will then activate stats that translocate to the nucleus and activate other transcription of other cytokines, many of which are involved in inflammation, IL-1, IL-6, et cetera. On the right, you can see a diagram that sort of illustrates the structural design of the three approved IL-23 therapies. So the IL-23s will target the P19 subunit of IL-23. The P40 subunit is present on both IL-12 and 23. And so this is what ustekinumab targets. So the IL-23 specific antibodies vary with regards to their FC receptor, of which guselkumab has a native, so it binds to CD64 on the surface of dendritic cells and macrophages that are producing the IL-23, whereas the others have mutations in this domain, which are designed intentionally to work on their durability in terms of immunogenicity as well as half-life. And so those are the major distinctions of the structure. So moving to the Crohn's disease data, these are I'm going to briefly just have a slide on each of the approved therapies, just to show that in risankizumab, we have the ADVANCE and MOTIVATE trials. The ADVANCE was a mixed bio-naive and bio-exposed, and then the MOTIVATE was only biologic exposed patients, and you can see that in both studies there were significant benefits for both doses. This is just the induction data of the IV infusion, 600 and 1200, as compared to placebo. This was a re-randomization study so that the responders at week 12 were then re-randomized to either placebo or two of the maintenance doses. And so when we look at this, you can see in Fortify that not only are there really high rates of clinical remission at a year, but actually the placebo rate, right? And this, remember, this is, all these patients received induction doses with risankizumab. And so when we talk about some of those modifications that increase the half-life, maybe this is why in clinical remission we're seeing this big placebo bump. When you look at a little more rigorous endpoint like endoscopic remission, you do see that there's a very nice separation with those placebo withdrawal patients. So for guselkumab, I'm representing the GRAVITY trial, which is the subcutaneous induction, but there also were 2 IV studies, which are the GALAXY 2 and 3. I will talk later about those. But so this is just showing, again, using an all subcutaneous regimen, that, again, we're seeing very nice deltas between guselkumab and placebo. And this, as opposed to the design for the risankizumab studies, was a treat-through design. So you can see actually the true difference between placebo and the medication. But you can see for, you know, in the overall population and in the subpopulations of bio-naive versus therapy exposed, that there are actually quite pronounced differences, slightly less in the bio-exposed, but actually quite better than some of the approved therapies that we have. So showing that it works both in your bio-naive and your bio-exposed patients. And then lastly, the VIVID-1 trial was looking at mirikizumab, and this was looking at co-primary endpoints at week 12 of clinical response and endoscopic response at week 52. And so they looked at 2 different ways: patient-reported outcomes, abdominal pain and stool frequency, or by the Crohn's disease activity index. And you can see both in the bio-naive and the bio-exposed population. Again, we're seeing this nice trend. So as a class, this seems to be a very good first-line agent, but also for bio-exposed or bio-experienced patients in Crohn's disease. And then, so we have a few head-to-head data, and each of these actually has data specifically against ustekinumab, which are very helpful, I think, for us to use in clinical practice. Sequence was an open-label trial, meaning that this was not blinded, and all patients were TNF exposed, right? So we're talking about second-line use here or later, and no patients could have been on ustekinumab prior to this. And so we're looking at the primary endpoint, which is a non-inferiority endpoint, which is the clinical remission at week 24, and then all the others were designed for superiority, and you can see that risankizumab on all endpoints was about a 20% delta for clinical remission, achieving non-inferiority, but obviously numerically performing better. And then we see for our all of our other endpoints achieving superiority, demonstrating in this open label format in TNF-exposed patients that there was superiority, and that has started to make its way into the living guidelines, I think, or at least will probably make it into some of the future studies. For guselkumab, so this is from the IV induction study of the GALAXY 2 and 3, and so these patients all received, and this was a treat straight through as well, were induced with either guselkumab at the same doses that, at 200 milligrams, at week 0, 4, and 8 versus ustekinumab, which was given via the standard dosing, 90 milligrams at week 0, weight-based dosing, 6 mg per kg at week 0, and then standard 90 milligrams every 8 weeks versus placebo. And so this is not commenting on the placebo data, but so this is in a randomized control trial, and it is not specifically in the TNF-exposed population. And you can see that for endoscopic response, endoscopic remission, and a composite of clinical remission with endoscopic response, that there was superiority that was met. For clinical remission alone, there was no statistical difference between those groups, just to keep in mind, but also showing very, very nice data data that, again, are we putting the dagger in ustekinumab? Obviously, one of the major changes is that ustekinumab is biosimilar now, and so obviously for the payers, this is a big consideration that they're promoting, and so may cause some strife with the authorization process. Lastly, I will show you data from the VIVID-1 trial where they also had a ustekinumab comparator arm. One thing I will highlight in this, while there was no difference that was statistically different between ustekinumab, look at the numbers for your clinical and endoscopic responses with ustekinumab, right? We didn't see that in either of the last two slides. We saw around 30%, and we're seeing 40 to 50% here. And so in no trial have we ever seen ustekinumab look this well. Obviously, we're seeing great efficacy numbers for both of them, but because of this, the head-to-head data do not actually show this superiority for mirikizumab over ustekinumab. So, moving to UC, I thank David Rubin for creating this so that I don't have to show you individual slides for each of them. But this is a nice summary, and I'll just highlight the bottom row for you, which is really highlighting all of the approved therapies. We know they're all better than placebo, and this you cannot compare between clinical trials, but it's nice to sort of look at some of these deltas. And I will highlight that on the bottom, for ustekinumab, we're seeing around a 10% induction delta between ustekinumab and placebo, and then for maintenance around 15 to 20, depending on which, the approved regimen is about a 20% delta. Looking at Riza, Miri, and guselkumab, you can see again, we're in a similar ballpark. With the highest effect size seen in guselkumab at the higher dose of 200 milligrams every 4 weeks. And we have the numbers for risankizumab at the doses we're using at 12 to 15%. So what about the biologic exposed? And I tried to sort of put all three on one slide just to show you. For UC, the data are really strong with guselkumab showing that both maintenance doses, and this is at week 44 for guselkumab and then 52 for the other two studies. And you're seeing that there's a really nice separation for the bioexposed patients with guselkumab. There is a separation in risankizumab, but that number is, the effect size is much smaller. And I just tried to see how I could fit this on there, so I chopped the table here for the mirikizumab, but you are seeing this is only among patients with one prior TNF failure only, and not other advanced therapy exposures. So it's a little bit different way to sort of dice the bio-IR population, but you are seeing that there is a clear effectiveness in this population, right? So if we're thinking about how can we use this, clearly Crohn's disease for both bio-naive and bio-exposed, we have really awesome effect sizes, and I think in particular that we haven't seen with a lot of other therapies. In UC, I think that we're clearly seeing that you can use it also in bio-exposed, so first or second line, and there are some differences between the clinical trials, and I think we'll benefit from some real-world data to inform, because clinical trials really don't reflect our real-world patient populations, how these actually perform as we move forward. So just a note on safety, and we sort of heard some of these concerns before. I've seen people put a blank slide here because not that it should be minimized, and all of our approved therapies have adverse effects, but if we look at the placebo comparisons, the rate of infections and serious infections really are not increased as compared to the placebo groups, right? So even though infections can occur, and that's how it's labeled, they're not super high. We heard about the fungal infection risks. I think in the real world, I fortunately haven't seen that yet, but obviously as we get longer-term safety data from their long-term extensions, we'll probably learn more about that. The class has a labeling to look at the liver enzymes, usually mild transaminase elevations. I think in one of the trials there was a more significant liver enzyme elevation leading to cessation of risankizumab, but that did resolve on stopping, and this is extremely uncommon. Mostly it's less than twofold elevation, and you can usually treat through this. Common adverse effects of any of our therapies are the most common with this class. All right, so lastly for this class, there are exciting developments in looking at oral IL-23. And so Icotrokinra is the first one that's coming through, and this uses a very similar mechanism to bind to and block IL-23 binding to the IL-23 receptor, and prevent the downstream effects of, sort of this promotion of Th17 responses, which are highly pro-inflammatory, and it's that break, the molecular switch that prevents the IL-10 producing regulatory T cells and sort of restore the anti-inflammatory response and promote the promote the anti-inflammatory and inhibit the pro-inflammatory. And so these are data from psoriasis, and just to show in a head-to-head against placebo and a TYK2 inhibitor that for all of their clinical outcomes in psoriasis, that this proof of principle that seems to be a highly effective therapy with really good achievement of their endpoints, similar to what some of the parenteral agents have shown, and no difference in terms of adverse effects numerically lower than deucravacitinib. Here is the first study that actually was just, thankfully, ECHO came about a month ago, and I was able to update this talk. But looking at the use from the Anthem trials, where we're looking at some of the, we don't have the clinical outcomes yet, but we do have some of the biomarkers and genetic signals here. And you can see that very nicely, as early as 2 weeks, we're starting to see CRP and fecal calprotectin come down. And then for the IL-23 gene pathway, you can see all the way on the right is what a healthy control looks like, and you can see how IL-23 pathway is really upregulated in active IBD, and so placebo really doesn't change that, but you can see that these gene signatures for inflammation really shift towards that healthy control balance just after, what is this, by week 12 and 28, you're seeing really nice downregulation of this pathway. So proof of principle concept that this looks like a promising medication, and those trials are now recruiting further. We're going to move on to TL1A, and so this is TNF, tumor necrosis factor, TNF like 1A, also TNF SF superfamily 15. And so this basically somewhat overlaps with both TNF and the IL-23 in that it's expressed on some of the same cells, right? Our antigen-presenting cells, our monocytes, macrophages, dendritic cells, but it's also in things like synovial fibroblast, right? So potential implications for rheumatologic conditions. And TNF promotes fibrosis, and so does TL1A. And so if you block this EMT, the epithelial to mesenchymal transition, you might be able to theoretically block fibrosis. So that's why there's a lot of excitement here. And so if you look at tissue from patients with ulcerative colitis or Crohn's disease, this is overexpressed, and this does disrupt the mucosal barrier, right? So the inflammatory cells and antigens from bacterial cells can get access into those cells. And you can see that some of the pathways, like on the left, are involved in fibrosis, but also apoptosis and other inflammatory pathways that we might be targeting with TL1A antagonists. So we have 3 trials that have recently read out some phase 2 data. So the first is I just realized it's tolisokibart. So we're moving from MABs to BARTs and other names, which is sort of scientifically derived. But the Apollo and Artemis studies were using this molecule for Crohn's disease and ulcerative colitis, respectively. And so you see that this is IV induction. And then the readout was at week 12, and then responders were re-randomized to 2 of the maintenance doses, and so this was sort of open label and no placebo comparison. And very similar for the ulcerative colitis data. So here you can see some of their efficacy endpoints as well as safety data. And just to show that we're seeing clinical response in Crohn's disease based on a Crohn's disease activity index of around 2/3 of patients. This is induction, and then they're in the blue bars, and then the maintenance are the green bars at the 2 doses. But if you're looking at a composite of endoscopic and clinical response, about 16% in induction, 22% at a year, and then steroid-free clinical remission in about over a third of patients at week 50. Safety signals really, the most common were infections, and this was done during the pandemic, so COVID was one of them, but no serious adverse events, deaths, or really not a lot of discontinuation due to the medication. So it seems to be well tolerated. And if you look at the UC data, we're seeing very similar signals where clear improvement here, right? And so we're seeing, this one actually was placebo-controlled, and you do see a nice difference between placebo, but at week, at week 12 and 50, again, histologic improvement, mucosal healing do look fairly robust, seeing that in the 50 to 70% range, which is promising. What's really exciting about this is that there is this companion diagnostic, right? So if we're trying to predict who's going to respond to a medication, currently with any of our medications, we don't really have those tools. And so this is looking at a diagnostic high or low, and you can see about 25% of patients had this, 25 overall, a 25% difference between placebo and the medication. But if you have the patients who have the companion diagnostic and those who don't, you do see that it starts to separate, that there is, some efficacy differences if you're diagnostic positive. So I think that these are encouraging signs that we have, potentially a smarter way to use this medication. The second is afimkibart, and so this, the Tuscany 2 trial did study this among 245 patients, and so this was placebo-controlled, and so this was 150, 450 versus placebo, and carried out to a year, and so looking at a lot of the same type of endpoints. So here the safety is on the bottom, where, again, the most common things were common that we see in all these clinical trials. But on the right, if you're looking at your induction dose on the response on the top, we're seeing clinical response rates, a difference of 24% in the lowest dose, all the way up to sort of across all doses in induction. And then if you go to maintenance, you're seeing rates that are 71%, 67% at a year. So this is very promising, again, showing that we're seeing, again, with both the IL-23 and with TL1A, rates that we really haven't seen, and effect sizes that are among the highest that we've seen. And last, this one is not a BART, but a TUG, so duvakitug. And so these were drawn very nicely by Jordan Axelrad for me, so I have to acknowledge him, but just because this was a table form, but nice to look at in graphical form. Just looking at Crohn's disease, and so this was a phase 2 study looking at the subcutaneous induction, right? So no IV, and then followed by the subcutaneous maintenance of 450 or 900 milligrams versus placebo. And again, this is looking at the induction dosing response, and you're seeing 50% at the higher dose as compared to 13% in placebo for endoscopic remission. And this is really works. Both doses seem to work really well in the bio-naive on the right, but if you look at the bio-IR, the higher dose also has a really profound effect on the clinical efficacy endpoint. So I think that this is promising in both Crohn's disease and UC, and I won't go over those numbers just to show you that there's a lot of promise. So then for the maintenance doses, you're seeing that around 58% in the higher dose at 1 year, and 55% in the Crohn's disease trial. So again, carrying these efficacy numbers forward. So beyond these, there's a number of people that are looking at TL1A and relevant to the combination talk. Some companies are sort of looking at longer acting TL1A as well as combination with IL-23 or with anti-integrin therapies. And then another one on the bottom is making a bispecific that includes TL1A. And this is not an exhaustive list, just to show you that there's so much interest in this, and specifically targeting it with, since there is this overlap with a lot of the other pathways, maybe, and the safety signals are pretty good, that maybe we can find a nice way to combine these. All right, so one that was not on this diagram is microRNA, and so I'll briefly mention the data for obefazimod. And so this is a really exciting thing, right? So who in the room has heard of microRNAs? And I always, Okay, good, a few people. But I find it difficult to sort of, think about some of these new mechanisms where all of a sudden we're learning about them, right? When the anti-integrins came around, you're like, what the heck is that, right? And so I feel like a lot of times we're learning as we go. But really what these are, they are transcriptional regulators, right? And so they can turn on and turn off switches, right? And so I can never remember the numbers, and so I always have to look at the slide. But microRNA 124 actually turns off, it sort of down-regulates the translation of cytokines that are going to prevent inflammation, and so when it binds to the cap binding complex, and then this is going to promote MIR 124 release. This is going to decrease translation of pro-inflammatory cytokines, and so the downstream effectors, IL-1, IL-6, IL-23, a lot of things we've seen a lot in TNF, right? So it's basically blocking the transcription of factors that are going to promote this inflammation. So a different way to sort of talk about some of the similar pathways. And so this is a phase 2b trial, the ABTEX 1 and 2, and this was in ulcerative colitis. And so it's looking at week 8 induction dose with or without bioexposure. So the bioexposed on the left and not bioexposed on the right. And you can see placebo versus 25 or 50 milligrams of the ABX 464. And so you can see in induction, the clinical remission in the bioexposed group is a 10% absolute difference that was statistically significantly different. This was for clinical remission. For clinical response, seeing over half actually responding by week 8, and then endoscopic improvement in about a quarter at the higher dose. Without bioexposure, you can see that this is extremely robust, looking at numbers for clinical response in the 2/3 at week 8 and endoscopic improvement in the 40s. So, I think that these are really intriguing data on something that's an oral agent that is something completely different than we've seen. And here are the week 48 and 96 data. So we have actually out to 2 years here. And you can see that clinical remission rates are in the, of patients, again, that are remaining on therapy, in the 50s, clinical response rates that are over 3/4, and really good response for the other endpoints like endoscopic improvement and endoscopic remission. So I think we'll be seeing more about that. The last oral therapy that I will mention is this Morph 057, and this is an oral alpha-4 beta-7, so sort of like the oral anti-integrin. And so it's interesting, right? So we are thinking about a gut-restricted, parenteral therapy that's, made for safety to just bind the gut. These orally active compounds really also we can think of as gut selective because they're really modifying the inflammatory milieu topically within the gut. And so, but still thinking about it either IV or sub-Q induction versus an oral pill. This is looking at 100 milligrams twice daily. In an open label fashion, and we're seeing, looking at things like histologic remission via the Robarts histologic index, that's about 23% at week 12 and going up to 31% at week 52. Clinical remission around a quarter at week 12 and week 52. And when we think about how our anti-integrins work best in our bio-naive population, it looks like that holds true for this with the bio-naive patients separating from the bio-exposed patients. And so, the week 52 data are a little bit, will need to be followed up here because obviously we would prefer to see a little bit higher numbers there, but so we'll see how that pans out. So that was sort of a tour de force about some of the most recently approved agents and some of our leading candidates for the next line of therapies. And this is in no way an exhausted list because there are so many different MOAs that are being explored. But I think, maybe we can get at our inflammatory pathways in different mechanisms, and maybe this does open the door to sort of think of novel ways to use them, the timing of using them, how we can, sort of look at bio-naive versus bio-exposed populations, and maybe how to combine these. And so obviously all of these things have shown really strong efficacy, among the strongest that we've seen, comparing to that second slide I showed you with this 25% effect size with infliximab. And what's great about it is that the safety signals for these newer agents are really, by and large, much better than what we're seeing with TNFs. And so if we can have at least as good efficacy without those safety signals, I think that's a win. If we can have better efficacy and better safety signals, then we're having our cake and eating it too, right? So I think that's great. And I think that is my last slide. And with that, are we moving? Oh, we have one more and then the panel?
Panel.
Panel. All right, very good. Thank you.
Thank you, Dana. Okay, thank you, Dana. Thank you to all of our speakers for the morning. If you don't mind coming up, we're going to do a panel discussion. So come on up and have a seat. We're going to get some microphones out. And then what we're going to do is open it up to the floor and ask questions of our speakers. Please feel free to raise your hand. We'll come around with a microphone and allow you to ask questions. Yeah. Oh, okay. How many do we have? You can use this one and I'll stay with this one. All right. All right, we're in business. Okay, so, question from the floor. Perfect, thank you.
Hi, Angelina Collins from University of California, San Diego. Question for Dr. Scott plus panel. Comment for me, please, to better understand if there's an active comparator arm in a clinical trial study, right? That seems to be looked at a little differently than a head-to-head. And I'm just wondering if you can help me think through that, if you can sort of understand where my question's coming from. So we kind of say positioning in Crohn's disease, oh, there's one head-to-head study in that sequence. However, if there's an active comparator arm in the guselkumab study, I'm trying to understand better what the difference would be between the active comparator arm and a head-to-head, if really you're looking at outcomes on how product A is doing against product B. Walk me through that a little bit more so we can understand that. Is that a reasonable question?
Absolutely.
Great question. One piece of editorial commentary, and then I'll address your question, because I wanted to say this when I was up there at the podium, and I didn't get the chance to. I personally believe that that the idea of conducting a placebo-controlled trial in IBD no longer has equipoise, and I urge our industry partners to move past that. That being said, they're equivalent, and so the ACG made their recommendation, risankizumab versus ustekinumab based on sequence, because that was what was published at the time. You can view the guselkumab and active comparator ustekinumab as equivalent. It just wasn't ready for their guideline preparation yet. And when the AGA made their positioning recommendations, those analyses were included in our network meta-analysis. So they're the same.
Okay. It just felt like such a funny call out, and I keep thinking, like, why are we missing that? Like, and then I'm thinking, what am I missing? What don't I understand about? Are these not really the same in their in how, I can't think of the word that I'm looking for, but anyway, thank you for explaining it.
Yeah, they're the same thing. And so you look at all the IL-23s, and the active comparators are head-to-head, for sure.
Thank you.
Bobby. Welcome back, Bobby.
Thank you all for your talks. Just a question, I guess I'll direct it to Dr. Johnson, but the rest of you can chime in. With adjusting therapies, the IL-23s have been nice for kind of our incompletely controlled patients on ustekinumab. So I've made a lot of switches to try and optimize them. I had my very first patient who was in long-standing remission on Eusta, and because of insurance reasons, actually, we switched to an IL-23, and she flared for the first time in years. So we're now trying to backtrack and see if we can fight with insurance to get her back on her brand name Stelara, which she wanted to stick with. But just curious if you've seen that, and having to move backwards from, IL-23 to 12-23, or is this just a random, fluke and she was going to flare anyway because it was time?
I think that is just the conundrum of IBD care, right? Like all of these numbers that we look at on the screen with 50% this and 30% that, the way I talk to patients about it is say, you have a 30% chance of being well, right? So it's not a chance that you're gonna be 30% better. So every single drug has its Vegas odds, so to speak. Not that I know how to gamble because I'm terrible at it, but besides the point, every drug has the mechanism, every disease has the mechanism, and we can't match them yet. And so I think that may be what you're seeing in the sense that for that particular patient, ustekinumab works better for that particular patient, and we see that all the time. I've seen that with the JAKs where a Xeljanz patient was partially controlled and we switched them to UPA and they did worse, and the data should suggest otherwise. So I just think it's the quirk of the disease. And then you brought up another really good point, which is patients who love their brand name product and the pressure from insurers to switch to the biosimilar, and then the duty that we have to sort of explain that most of the studies have shown equivalency / interchangeability depending on what the companies have done in front of the FDA, and waiting 6 months fighting with insurance to get back to Stelara when you could have a biosimilar, may not be in her best interest. So it's just tricky all around.
This question can go for the Ed Barnes from UNC. This question can go from the panel, but maybe to Kale first because your talk was really good. But you're talking about mechanisms of combination therapy, and this may be anecdotal, but I've had quite a few patients that have done really well on combination vedolizumab plus JAK inhibitor, and it almost seems, this may be again anecdotal, but it's synergistic. And you showed us the Vedo plus UPA from ECHO last year. Then at ECHO this year, there's another Vedo UPA study, and then there's a Vedo Tofa study that was presented and that is also still ongoing. And what it seems like is that even during induction, you get better rates than Vedo or either of the JAKs alone. And in these really refractory patients, it seems like there is something to that. So I just wonder, given that you had a nice cartoon of the mechanisms and you really delved into this, is there some reason that that particular combination would be better? Because these are patients that are basically facing colectomy. That's why we're doing the combination, and it seems to be working. Or is it just that to your point, that this is just their lucky chance in terms of odds?
Yeah, I mean, and I think that I know what you're saying. I understand what you're saying. And I think the jury is out on why that might be. Is there a synergistic component to it? I think that's very likely there is. I don't have a mechanistic way to explain that, and that's part of why I was kind of emphasizing we just have to do the studies and see which work better. And sometimes the preclinical studies lead the clinical, and sometimes the clinical leads the preclinical. And that's one of these situations where I think that what we see clinically, maybe we'll get an answer for why at some point. I think there's probably something there to that combination based on those data, but I don't have a good reason why. I mean, if you. I can't say more than that, to be honest with you. Maybe we'll find out that there's some overlay on the pathways or that something's going on. I think when it's a one-off, when it's like one patient happens to do better, I can more easily explain that by patient heterogeneity, and perhaps that patient just happened to have defects in both of those pathways. When you're seeing it repeatedly in multiple studies, to me, that's telling me that there actually probably is something there. And that's one of the kind of exciting parts of the future of looking at these combinations, is figuring out which ones are synergistic and which ones are maybe antagonistic to each other, and so forth. But yeah.
So I would add, first of all, when I'm thinking of combo, you want to look at, sort of the spectrum of activity, right? And so one of the attractive things about Vedo is that it's a very safe medication, right? And so, we did see some data for TNF and JAK, which is, in my opinion, a little bit cowboy, but, I do have a dermatologist at my center who does that, but I think, so you want to maybe take something that's a little broader, like a JAK or TNF, and then combine it with something that's maybe less likely to have systemic adverse effects, right? And so Veto fits that profile. And I guess, if I'm thinking about this, Veto I don't think works immediately because there's been some nice studies at DDW that have shown if you look at the lamina propria in Crohn's disease, or if you look at ulcerative colitis, you're seeing this is packed with these lymphocytes, right? And it takes time for those lymphocytes to clear, right? And so by the time you get those lymphocytes out, then you have if you rebiopsy in maintenance, you actually see no lymphocytes in the tissue, right? And so now you have the Veto doing what it's supposed to do, but it takes longer, right? So if you take the JAK that works immediately, and that study that was at ECHO, the Exogem study, is only 8 weeks of TOFA, and they're seeing really promising effects. I think because it's like that jump start to get the medicine to work. But I think because the mechanisms are different, right? And because the overlap with all these things, maybe to play devil's advocate, if you've optimized a medication that's adequately blocking TNF, IL-1, IL-6 via whatever mechanism, then you prevent the white blood cells from getting there, then maybe there's some synergy there.
Ed, did they present any mechanistic data or talk about doing that down the road?
No, they have not. But I mean, I think it's something that needs to be done though, because I think to Kale's point, this may be where the clinical feeds back to, and if anybody knows the answer to that, let me know, because I'm just intrigued by it, because outside of the trials, like we've had multiple people that. Sorry, I should use the mic. But we've had multiple people that have done really well on this combo, like more than you would think are just refractory people, and like. Outside, and because originally it was like combo because maybe Veto doesn't treat it EIM, but now we're using it like during induction, and it just works way better than I would have ever thought it would. And so it seems to be when you think about all combinations, this one seems to be better, and there's multiple studies to suggest that now.
So with that experience, are you positioning that combination higher up compared to certain monotherapies?
That's a good question. I don't think right now I'm like jumping to that, but I would say like a year or two from now, we probably will, because I think there's also logistically a reason to do that, in that you have an infusion-based therapy and a pill, and it's going to be much easier to get that approved than it is some of the different biologics, where it's not a biologic and a small molecule. So from just a logistic of getting the two therapies approved in an insurance standpoint, a lot of these combos are really hard to fight for unless you have a dermatology colleague or, like Dana said.
That was going to be my question, is what role do our living guidelines or guidelines in general have in facilitating our ability to do these really fancy combinations that we're all super excited about, and how we live in the real world, where that type of insurance approval can be really challenging.
We're going to need these clinical trials to actually get to publication standpoint. They're going to have to be beyond sort of observational data collected over a cohort of patients to actual trials to meet guidelines. But it doesn't mean it shouldn't be things that we should be thinking about incorporating into our care. It's just the guidelines are pretty stringent about the quality evidence that's required to enter them. I think this is a really neat approach, and I also wonder sort of downstream if that combination of a JAK plus Veto also offers the opportunity 6-12 months down the line for people that are doing really well for withdrawal of the JAK too, because we know that you can go back and forth with JAKs, don't have to worry about things like immunogenicity, and then let the Veto be the sort of long-term safe maintenance agent too.
I'd like to make a comment before we have a question here. So I'm not convinced we actually know how Veto works. Yeah, it blocks lymphocytes, but it does more than that. And I would have to go back and PubMed the studies that showed, it affects dendritic cell function, and it's got some other effects that we don't understand. And then it may be off base, but if I'm going to advanced combo therapy, I often tend to go towards something they've already had a partial response to. I got a partial response to this drug, let's add something to it, rather than going to something completely different, combo that when they failed those mechanisms before. Frank?
Yeah, there is some evidence that the alpha-4 beta-7 blockade actually causes like an imprinting effect on lymphocytes. So even if they go in and out of the tissue, then blocking that might have some sort of broader. So to your point, that has been looked at a little bit on the preclinical side of things, and I do think there is something to that as well.
I just want to commend everybody for just absolutely phenomenal talks. This is just really, really great. I had two questions for two different people. I'll start with Dr. Clem. With the CAMs, it was a really, really great talk, covered a lot of ground. How are you approaching this in your clinical practice, are you waiting for people to bring this up, or patients to bring this up to you to then counsel them, or are you being proactive? And I think we have some data, particularly looking at the curcumin and curcuD stuff, where there really may be an adjunctive role in some of these patients, and how are you approaching that? And then I'll let you answer, and then I have a question for Dr. Steiner.
Yeah, that's a great question. I'm doing a little bit of both. I think we all we have those patients that come in and we know right away that they're more interested in chem therapies or natural therapies, or, more hesitant to start advanced therapies. And sort of I start that conversation pretty early on, even in that initial appointment. Otherwise, I think it does come up a little bit later, sort of in follow-up appointments, just because there's so much ground to speak about otherwise, but I do always ask about extra supplements and like why they're taking them, how long they've been on them. But certainly those patients that are coming in with like a list of things already, I discuss it right away.
I mean, some of the data you showed allude to the fact that they're probably doing all this stuff kind of behind the scenes, and so we have a limited time to cover a lot of different topics in our appointments, but maybe this should be something we're looking at covering a little bit more proactively.
Blair, before you move on, I just want to maybe talk a little bit more about this topic since we're on the curcumin. How many people in the community or in the audience that are providers are advising their patients to use curcumin or curcuD? Quite a few. Natasha, can you talk a little bit about how you advise patients to actually use curcumin, what dosing you're telling them? And I'm talking specifically about UC.
Yeah. So, I mean, really the data shows that it's for people who are like mild to moderate UC and not to be used as monotherapy. I think, I use it as a way to really sort of build and establish rapport with patients as well. Like, I want you to be on the 5-ASA, but I also want to sort of respect the fact that you're wanting to use more natural therapies as well, and so we can use both of these together. The data shows that anywhere from like 1 to 3 grams of curcumin a day is what's really effective. So typically that's what I'm saying. I mean, the problem with supplements is that there's so many different types of supplements out there. And some of them are more pharmaceutical grade, so that they've gone through a lot more rigorous testing. They're definitely more expensive, and ones that you're not necessarily getting over the counter and may have to get through some other sort of practitioners like naturopaths and stuff like that. And I do definitely speak to that because I don't want patients to be purchasing a lot of supplements and they're just essentially sort of, it's money down the sink because they're not adequately absorbing them. They're not sort of the bioavailable kind of bioactive compounds that we need. So I do discuss that as well with my patients.
Do you tell them to take the 3 grams all at once, or do you do it split dosing, 1.5 BID?
They could do it all at once if they want to, or split dosing, yeah.
Great, and then one last question to Dr. Steiner. Great talk on the combo therapies. And this kind of loops in what John was saying. Is there, and there's probably a knowledge gap here, I recognize that, but is the fact that they failed a monotherapy a reason not to use that in combo? Or are we really looking at trying to find areas where somebody's had a partial response that we're going to add to? And any commentary from anybody else who's doing this would be welcome.
Yeah, I mean, I'd love to hear from the panelists because there is a knowledge gap there. I think, to me, it does make the most sense with what John said is try your best to select something that they've had at least a partial response to. That would suggest that you might get something out of it. Whether or not to try a second agent in the same class depends on a lot of things. To me, if it was, a long time ago they tried anti-TNF, you're not sure if they actually were optimized, you don't have drug levels, that's something I wouldn't hesitate to go back and try another anti-TNF in, or maybe even the same one if I was convinced they had been optimized. If it was someone that in your care, you got them on infliximab and had 20 plus drug levels and no antibodies and 0 response, then the anti-TNFs, for example, would fall to the bottom of my list of what I'm going to combine. But it's not an absolute. I mean, because at the point we're at here, we're kind of grasping at straws when we're reaching for these because, at least for me in my practice, I don't use these until they failed a number of things. So I wouldn't really say anything is off the table except for a prior adverse reaction to a drug. But I think where trying a second agent within the same mechanism, I would say that falls somewhere in the medium to low on what I would want to go for. But sometimes that might be the only option you have for these patients. So that's kind of how I would approach that. But there is a bit of a knowledge gap. I don't have, I don't think we really know in the context of combination therapy. There's some data about, switching from second anti-TNFs, and sometimes you do get an effect switching to a second one. So for that reason, I would not just take it off the table.
On the topic of using a drug in the same class, Frank, did I see correctly that there was a recommendation to switch from one mesalamine compound to another one if it wasn't working? Against it. Okay, I misunderstood. Okay, never mind.
With the exception of the addition of PO and PR. Yeah. which-
Okay, good. All right, that didn't make sense to me.
So I just wanted to add, I think that that question is important, and you got, Caleb got into a lot of the reasons why you might try another agent, right? And I think it comes down to how it was used. But when I'm thinking of combination therapy, it's also, why am I doing combination therapy for this patient? Are they severe and refractory, in which case it's going to be a lot of trial and error? And in that case, I would generally say, if you had a primary non-response to an anti-TNF, I'm not reaching for another TNF. But if we don't know, then I'm more likely to use that in combination. I certainly wouldn't use the same one in that case, and I might reach for the other one if I've really exhausted all my other options. But the other reasons we would use combination are that maybe a patient has extraintestinal manifestations, and we're going to try to hit one with one medication and one with the other. Are we doing it because of, the patient has luminal response, but their perianal fistula is not responding, right? And then I'm really going to reach for something a little bit different that maybe has good fistula data, right? So I think you have to not only think, right, and so you got a great job outlining the different mechanisms that maybe would be appropriate for everything, but also think about why we want to combine them, because that really, to me, helps me decide with the patient what's going to be the easiest and most rational combination.
Thank you for that as well. And then just think, as you were talking, I was kind of thinking about the question. And one other potential scenario is when you get to this synergy question, right? Because, we just talked with Dr. Barnes, there's potential synergy between these. If we happen to discover that an agent has synergy with another agent, that might be one other reason to say, we'll try it again with this, because we don't know if that synergistic effect is going to get a bit of bump. So, but again, this is just kind of thinking about it. I have no data to support that thought.
I feel like I'm in a corporate boardroom hearing synergy so much. Ben Click, Colorado. I have a question that's kind of geared towards Frank, and then may trickle down to Dr. Johnson and Dr. Lucan as well. So you highlighted that one of the discrepancies in the guidelines, AGA versus ACG, in terms of the outcomes that were primarily assessed in the AGA guideline, the corticosteroid-free clinical remission, and the discrepancy being endoscopic remission. And I think one area with which I struggle, and I'm sure others do as well, is this push towards treat to target, towards mucosal healing. We don't have great data clearly showing that endoscopic remission when you have disease activity endoscopically, but you've achieved clinical steroid-free clinical remission, what do we do in that scenario? And I know that's an area of active investigation. So my question is kind of clinically, how do you think about endoscopic remission as being a firm endpoint, and how hard do you push to achieve that when somebody is feeling good?
Yeah, I think that's a real challenge. Like you highlighted, there is an active multi-site clinical trial that's being funded by PCORI to try to address some of this right now. I think you have to take into account the entire patient sort of holistically in this decision making. What agents have they failed before? What their values are. I hate to use the sort of nebulous, touchy-feely shared decision-making phrase, but I do think that, if we're talking about dose optimization of an existing therapy, I think that's an easy move with relatively low risk across our current advanced therapies to pursue. I do think that there's tangible risk in switching to an alternative MOA when somebody's in clinical remission, that it's really important that you discuss that we know that this pathway is working for you. You are better than you were 6 months ago. Do you want to switch to another drug that may not work for you and put you back to where you were, and we don't have a good sort of biomarker to sort of identify whether or not you're going to be responsive to the new therapy? I think you have to also then take into account sort of how severe the endoscopic disease is and what sort of disease-related complications they're having. Is this Mayo 1 colitis in somebody who, like I said, is in clinical remission, or is this severe deep ulceration in the ileum with impending surgery if you don't do something differently down the road. I think that there's no like magical equation to decide this, but you have to factor in all of those factors and then superimpose on that a layer of like risk tolerance, adverse event tolerance by, increasing the potential risks of therapies that you're using. I don't know if Dr. Johnson, you have a
That
similar
was so
approach.
well said. What he said, no. I think, targeting endoscopic remission makes it easier for us. Doesn't make it easier for the patient necessarily, because once they feel well, that's what they care about on a day-to-day basis. And we have to respect that, we have to honor that. When they don't feel well, even when they're in endoscopic remission, then they may start decreasing their therapy and looking for complementary things and kind of sneaking things into their regimen. So I think being aware of that sort of disconnect between clinical benefit and endoscopic remission, and are we treating ourselves here, is a really important question. For me, I think exactly what's been said. If the inflammation is mild and not causing systemic compromise, hypoalbuminemia, persistent anemia, et cetera, I may kind of let the therapy ride and take a second time point to check in with a second endoscopic assessment. Certainly in postoperative Crohn's, I have people who kind of stall out at I2 disease and they're there for 7 years. And I don't need to change their therapy. They have no symptoms, they're fine. And their ulcer is so similar from year to year, I can recognize it on their picture from their colonoscopy. And how do you know that that's going to be the case for that person and they're not going to progress on to 3 or 4 or another surgery? Well, it's, treatment over time, I think, and having that good therapeutic relationship and those open discussions with your patient. But yeah, be careful that you're not trying to push a therapy to perfection if it's not necessary. And then I think to kind of dovetail that, talking about these left field therapies that we're all very excited about, whether it's dose escalating IL-23s without a ton of data yet, or doing combination therapy with the new agents together. If your patient is sick and you have a partial response to IL-23, and it's going to take you 6 months to fight with insurance to get some more doses and escalate in this sort of data-free zone, you can switch them to another medication that has long-term data that we can escalate. Infliximab, still love you, right? So there's a lot of different options. You got to think about the whole clinical picture.
I would add that, STRIDE 2 is a guidance, not a guideline, right, for the purpose that I think it's a knowledge gap, right? And so, and to what both of my colleagues said, I think it really comes down to the patient. I think one of the conundrum are, say you have a young Crohn's disease patient with horrible ileitis, you look at them, I have no symptoms, I just, they're sent for anemia or something, it was incidentally found, right? Maybe you examine them and they're tender, but like they're not complaining about it. And it's a hard sell if they're feeling completely well, but their SES-CD is like 14. I would argue that you need to make a change because this person's high risk for needing surgery, right? So there are gray areas. What if you have, a patient who's 70s or 80s, right, and they have ulcerative colitis? So one of the main things we're treating to a target of endoscopic healing is to decrease their colon cancer or colectomy rate, right? And so if they have a little bit of smoldering disease, maybe it's different than someone who's 20 who's going to have 50 years of dysplasia risk, right? And so I think you have to look at that patient when you're making those decisions. And sometimes I think it is as good as it gets, right? So if this is their 4th line therapy and they're clearly endoscopically improved, but they're not at imminent risk of surgery or something terrible, then we may have to permit some of this, right? And that's maybe where we can get at this with the combination approaches and try to nitpick a little bit, but maybe adding in that situation is better because you don't want to risk losing if you're going to make a complete switch.
So Dana, newly diagnosed severe ileitis, would it be the end of the world if they get surgery?
Well, we have great data, right? So, from Scandinavia observational cohorts that early surgery may actually be better than infliximab for these patients, right? And so many of those patients who underwent early surgery never wound up escalating, at least for 5 years, to another therapy. I always worry that there are a large number of those patients by 10 years that may have adverse outcomes. But I think surgery has a clear role, right? We need to, one of the things, like very few, we heard it for one of the talks saying a surgical consultation that was declined. But I think we have to normalize that, right? And I think the earlier you talk about surgery, and when I'm presenting, a newly diagnosed Crohn's disease patient, I say, one option is to do surgery now, right? I'm probably going to recommend that you go on therapy later. But if I think you might need a TNF right now, maybe doing surgery, we can maintain you much more easily on IL-23 or maybe even Vado because, you're sort of resetting that slate, right? And so I think it absolutely should be considered. I think more so in Crohn's disease, right? UC surgery is the last stop for many of our patients. But again, I think in surgery, in UC, we also are very reluctant to use colectomy as medical therapy when in many cases it's the best outcome for the patient.
Hi, everyone. Holly Hamner from Idaho Gastro. Wonderful discussions this morning. If you have a patient who eventually ends up on combination therapy and there was a discussion earlier about the length of time for beginning to see improvement in symptoms versus the kind of ceiling of maybe we've reached the point where we need to choose to go versus stay. If they're on combination therapy, does the time to starting to see improvement change at all? And does your time frame to being willing to change something else again once you've reached that combination therapy, does that adjust at all?
I guess I'm up for that one, at least to start. We don't know, right, is kind of at the end of the day. I think based on the nature of the patient that probably is, I am probably giving it a little more leeway just because that is the end of the rope. You could try a different combination, for example, but just in general, even just for monotherapies, we don't have necessarily like an optimal time, right? Like Dr. Johnson talked about some different timelines for different drugs. A lot of it is subjective and anecdotal in what you do in your practice. I'd probably give them at least 4 months before I would call it, unless they worsened, right? So a worsening is kind of like an immediate stop for me for anything, combination or not. And then, a little bit of improvement, I might give them a little longer. So that's a long way of me saying there is no clear, that I know of for how long to try it. But based on the nature of the patient, I'd probably be giving them potentially, as long as I don't see bad outcomes, a little more time than I would just because I know that bag is getting emptier and I'm already near the bottom.
I just want to add one thing that we haven't touched upon with the combination. And obviously, when we look at the side effects or adverse effects in clinical trials, it's often that placebo group with active inflammation that has the highest rates, right? And so really, when these patients have really persistent inflammation, I think that's where the risks of combination therapy are more pronounced. And nobody's really mentioned steroids, right? But it might be very tempting to put patients on steroids additionally on these combination regimens. And so we have a cohort that we presented at DDW of 135 combinations. And actually, the patients that were on steroids with combination regimens were really the only ones that we started to see these bad signals in terms of adverse effects. So just while we're talking about that type of patient who's maybe not getting better, I think you definitely want to think about, like, I would say, again, it depends on why you put them on the combination regimen. But if they are feeling improved, then that may be good enough for that really refractory patient. But if they're not feeling better, then you might want to rethink it and switch things up. And certainly, if you're going to think about adding steroids plus 2 immunosuppressive agents, you should think about a PJP prophylaxis, number 1, and number 2, that a lot of these other adverse effects may start to increase.
Just 2 quick comments on that excellent comment, Dana. First off, it's important to recognize that steroids remain the most dangerous medication that we use in inflammatory bowel disease, more so than any combination of advanced therapies that we can currently deploy. Secondly, I would just caution that I don't know that we completely understand the adverse event profile of combination advanced therapies yet. We have a lot of meta-analyses that have combined a bunch of different combinations of therapies with no or null risk estimates. And I don't think that adequately drills down to what the actual risk is of different combinations. And it's going to take a lot larger population cohorts with follow-up time to really get to that. Not that I'm saying don't use it in the appropriate patient.
I was going to add one comment to this, and this gets at a bunch of stuff that's been talked about here, and to Dr. Click's comment earlier, and Dr. Lukin. I think one of the things that we haven't talked enough of, and I'm talking about not us today, but in general as IBD physicians, is how do we get comfortable with permissive disease, and where do we, and what's the type of patient and type of active endoscopic disease that we would be willing to let persist? And we hear in these talks about treat to target, treat to target, treat to target. We can only achieve that in so many of our patients. And so trying to figure out when it's okay to be permissive. And so to your point, or to your question, if they're doing better on combo therapy, maybe that's just as good as it's going to be. And how do you be comfortable with that?
Yeah, I mean, I think that's an excellent question, and probably a big knowledge gap as well. I think this would come up very frequently in our PSC patients, right? Huge dysplasia risk and cancer risk. Right-sided UC often is asymptomatic. The patient feels amazing, right? And all the time we scope these patients, they're, to get a liver transplant, you need to demonstrate all this compliance. But I find that for the IBD, sometimes I don't see these patients. I see them annually for a colonoscopy because they're really good at doing it when the liver team says you need to get your colonoscopy, but they don't necessarily follow up with me. And many times it's Mayo 2, like really pretty almost pancolitis, but it's right side predominant, so they're not having those symptoms. And obviously I don't want to have anything, so in that really high risk population, I'm really driving home you need to do this. And I had this conversation twice last week with patients. And so I think that's one group. But my older patient, I think patient, and I guess you have to have that conversation. How comfortable would you be with surgery? Would you want to have surgery if we found colon cancer? Sort of what are these, so for the older patient, I think it's a little easier to permit it. And for the patient with low risk disease, maybe that's fine. Maybe Mayo 1 is totally okay, right? We've seen some of the clinical trials, Mayo 0 or 1 is their endoscopic target, right? So I think that's probably fine, especially if that represents fecal calprotectin improvement, no rectal bleeding, et cetera, right? So I think that those are pretty easy. And I think if you have an inflammatory phenotype Crohn's disease where it's a couple of aphthous ulcers in the terminal ileum, but you've done, cross-sectional imaging, there's none of these high-risk features, doesn't mean not follow that patient, but maybe that's good enough for that patient because there's no high-risk stigmata. For all others, I think it becomes a much more nuanced conversation, and I think for me, the younger the patient or the more risk factors, the harder I'm going to push to achieve a deeper therapeutic target.
And I think that's the beauty of treat to target, right? That's where it takes that knowledge gap into consideration with the caveat of saying you need to individualize your target. So broadly speaking, mucosal healing, clinical remission, but what does that mean to the individual patient who's 80 versus 20, who has PSC, who doesn't, who's had a surgery, who hasn't? So allowing that flexibility of your target is where I think treat to target continues to be applicable.
So I'd like to make a couple comments. We have fellows and APPs in the room. We're talking a lot about combination therapy. This should be a minority of your patients. These are the patients who just don't respond to anything. And we've all got them, so which was why, and we struggle with it, which is why we're having this conversation.
But I don't know that that's always going to be the case. And, as Ed alluded to with the echo data, there may be a future where the combination up front is the appropriate strategy to get more aggressive disease control. We're not there yet, but I see that on the horizon.
Well,
Much like we never 20 years ago, pre-Sonic, it would have been taboo to combine an immunomodulator with
No, and
TNF.
I'm not saying it's taboo. I just don't want people to think that that's what we're all doing is putting everybody on combination advanced therapies.
And kind of to the comment you just made about 20 years ago, we don't want to wait 20 years to come up with the next best therapy. And what I fear is kind of what happened to ozanimod, right? It came out and then it should be positioned as your first drug, not your last drug, because it doesn't work after you're very therapeutic exposed. And yet you couldn't get insurance coverage for it. It didn't ever really make the splash into the market and it sort of disappeared. So having that support for those early effective therapies and being able to access them for our patients and then generate more real world data so we can basically keep the ball rolling and not wait another 20 years.
Just one question for all of you, I guess, on practical point on managing IL-23s. Obviously, we've used them for when they first come out, refractory patients. They need something else. We often get the question, do you switch between IL-23s due to efficacy? I personally don't, because I don't think the data's there and the studies are underway. I have switched patients around who have, maybe medication-specific reactions like severe arthralgias or rash. Just curious your approach. And then with mirikizumab, I think that's the only IgG that's separate from the other two. It's also the one that got the lower positioning in the guidelines. So if you're talking about efficacy, you might put Miri lower, but I think there were some study design issues with their Crohn's data that affected that too. So just comment on guidelines and practical management.
Clinically, I am totally on board with a 12 to 20 ustekinumab to an IL-23. I don't do a lot of IL-23 to IL-23 switching. I would say that, I'm okay with dose escalating IL-23s, understanding that it kind of is a data-free zone still at this point too, and we're still waiting for additional data on that as well. I think the important thing to consider when selecting an IL-23 that sometimes doesn't get incorporated into the conversation is time. And, I worry that if we have a sort of favorite IL-23 and we decide to engage in a discussion with our insurers about getting that IL-23 as opposed to getting an IL-23 that they may have on formulary, that we're doing our patients a disservice, as opposed to just getting them on drug as quickly as possible. I don't know if anyone else has other thoughts.
The only reason I would probably switch from IL-23 to IL-23 is for intolerance, which, sometimes skin reactions or other, things that aren't really well described in the inserts can happen to patients. So you might go to another one.
Okay, it's almost 10 o'clock. I heard it snowing, so we're going to try to wrap this up. I want to give Frank the microphone for just a moment because, why don't you come up here? He's going to make a quick announcement about IBD chorus, and then we're going to let you guys go. We're coming back at 4 o'clock. We're going to have snacks for everybody at 3:30. Please visit the exhibitors, have some snacks, and then we'll get started at 4 o'clock. Go ahead, Frank.
Thanks, Mark. So guidelines are fun and impactful, but this is something I get to do that is also super awesome. It's IBD Chorus, which is a quality improvement initiative that is supported by the Crohn's and Colitis Foundation. We're currently at 75 plus sites across the nation. It's a super awesome collaborative where we all work with each other to improve the care that we provide for patients with IBD, incorporating many of the same themes that we've talked about this morning. Our current sort of focus of interest is treat-to-target care, for example, and how we can optimize disease activity monitoring and assessment after patients start new advanced therapies. Prior breakthrough series have included things like optimizing urgent care access, reducing ER use, et cetera. We have over 6,500 patients enrolled at this point, with over 70,000 surveys collected on patients. Every patient that's enrolled in Chorus can fill out a paper or electronic survey with each of their visits so we can sort of track their disease activity over time. And this has really sort of helped support sort of the knowledge base with regards to quality improvement in IBD as well. Colorado joined the third wave of Chorus sites, and we've been a member since 2017 at this point, and Mark and I have spearheaded that. It's been really awesome. As I mentioned, it's a real-world collaborative. We all meet on a regular basis. We have monthly meetings in the evening where we discuss our current initiative and also include some clinical topics of interest, but then we also have semi-annual in-person meetings or virtual learning sessions, which are really awesome as well. We use longitudinal data to track our own performance. If you're a Chorus site, you get quarterly reports on how you're performing over various benchmarks, which is really awesome to see how you're doing in relation to the cohort and over time. And we are benchmarking and improving standardization of how we track these activities over time as well. Our prior work, as I'll show on a slide here, has reduced ER admissions, hospitalizations, and steroid use as well. Our prior breakthrough series was on urgent care use. Each site deployed a toolkit that included creating frozen slots, team huddles, a team navigator, et cetera. And just doing that it was demonstrated over time to reduce opioid use by 50% and then 20% reductions in ED use, hospitalizations, and steroid use. And then in several different formats of cost-effectiveness analysis, including markup simulation, claims-based data, it's consistently demonstrated this $2,500 to $3,000 in savings per patient per year for participating in CHORUS across the entire cohort. So pretty cool. These effect estimates have persisted over time. As I mentioned, the significant reductions in ED use and hospitalization. What's really cool is you can see these stepwise graphs across the cohort over from 2018 to all the way up to 2023. The urgent care breakthrough series stopped right here. And over the next 18 months, there was significant persistence in these effects. So the participation in CHORUS is optimizing how you participate in care for your patients, and that effect is durable. There are many benefits to participating in CHORUS. If you want to become a site, you can participate in our collaborative, obviously. There are a lot of opportunities with regards to affiliation with the foundation. If you are contributing data to the course, you also can participate in the research that we're conducting and participate in publications. We've supported a number of research initiatives through CHORUS as well. You get these really cool reports to track how your patients are doing, and then you can see how things are going from a CHORUS collaborative standpoint as well. It's very minimal time and effort. We do recommend that sites that want to participate in CHORUS designate a physician champion to lead that. There are opportunities for, you'll need to dedicate some support staff time as well. You will probably require IRB-related fees at your site, so keep that in mind. We have a whole IRB team that can help you if you want to join CHORUS. We do recommend that you travel to our annual CHORUS meetings. Right now, the cadence tends to be one virtual, one in person, but in years past, we've had 2 in person, so just keep that in mind as well. We do think that CHORUS is reshaping standards related to IBD-related care. These are just some comments from people that have participated. I'm a better doctor because of CHORUS. It's helped me improve patient outcomes and make impactful transformations. I think everyone that participates thinks it's been a uniformly positive experience. And we're always looking to add new sites. So Taylor Wires is here at the Crohn's and Colitis Foundation. She's in the back there. Taylor, you want to raise your hands? Yes, thank you. If you have any interest in joining CHORUS, you are not currently a member, please find Taylor at the Crohn's and Colitis Foundation table at one of our sort of meet and greets throughout the conference, and talk to her about joining. We have about quarterly-ish new site meetings where we review a much more in-depth slide deck about CHORUS participation. We'd love to have you join us. Thanks a lot.
All right. Okay, that's it. We'll see you guys this afternoon.